وعايز ابقى اسجل كلمه من اللي الدكتور طلعت على النت كده.
مش هنقفل،
خليها كده ما ده تيست ان شاء الله.
هو ده المؤتمر السادس السادس
ان شاء الله السادس باذن الله البي في دي جروب ان شاء الله. سيشن 10 11 سيشن 11 12 سيشن 3 سيشن 4
وفي نفس السيشن فعلا
في ايه؟
غير السيشن
في نفس
نفس
السيشن
السيشن؟
يوم الجمعة
بكرة
بكرة الساعة 1 بعد صلاة الجمعة.
معانا احنا برضه
معانا بالظبط كده.
احنا لينا حاجه الصبح
انت الصبح لا الصبح مبتدئين بالراحة على طول.
كويس قوي.
الحمد لله.
لكن بعد الظهر عندنا من 3
بالظبط كده. النيرسينج سيشن من الساعة 1 للساعة 2 نيرسينج سيشن الدكتور بيرتبها كلها فرايدي يوم
نعمل فضول تاني
فضول تاني بالظبط كده. عاملين فضول تاني من 1 ل2 بالظبط كده وياخدوا الشغل. احنا هنبتدي يوم الجمعة ان شاء الله من الساعة 10 ل 11 اللي هو الورك شوب مع امام بوليا شوية كلام خفيف للنواب. صلي الجمعة بعد صلاة الجمعة ما تيجيش كل موجود. ورك شوب ترانزليتيال ورك شوب اللي هنا في الفرع يبقى هنا ان شاء الله.
مش مشاكل. انا حاجات بس في التكست مش في الفيديو. حاجات في التكست مش في الفيديو.
التكست
هتدوس عليه مش هتدوس عليه من تحت كده.
من تحت ماشي.
تمام. PVD ريفريش. تمام. لا خدها كمبيوتر. احنا بنجرب على اللابتوب على طول كده نبقى نكتب ليست عشان كده اسرع. هو نفس الفيو بتاع الماك هتلاقيه بريزنتر فيو حاجه. لا في بروجكت
انت قافل؟ لا مش ماشي.
بس في البريزنتر فيو الفيديو بيبان هنا بيقول لك ناو بلاينج. تحب تجربه؟
جربها.
اوكي شغال. انا عايز بس اشغل البروجيكتور عشان نشوف الدكتور هناك اللي بريزنت. احنا عندنا
يلا كده
على الفيديوز. ماشي.
أول واحد.
ماشي كده. بس فاكر الفيديو الاول عشان تطمن قبل ما نشغل البروجيكت ده. اوكي، ده الفيديو الاولاني اللي قلنا عليه اولاني خالص. تمام. بعد كده هنا تاني واحد الفيديو ده
لازم اعمل اوكي كده.
دي بس لازم تعمل اوكي. بعد كده خلاص الباقيين هيشتغل بقى عادي. اما الفيديو بلاير ده لازم تدوس عليه. انا واقف كده كده جنب حضرتك طول الوقت.
يعني كل ما هدوس على الفيديو هيطلع لي البتاع اللي هو
اوكي
اوكي.
بس هما الاثنين دول بس اللي هما اللي معمولين دي، والثالثه اللي في الاخر.
بتشوف دي كده
يشتغل كده.
مش
لا
شايف.
ما انا مش على البروجيكتور دلوقتي، لسه هكونكت، بس انا بقول حاجه الفيديو شغال. اهي
لو عايز توقف الفيديو في وقت
هنا
معين.
اهو بوز.
دول شغالين.
دول كلهم ان شاء الله على السلايد الجديد. الفيديو الوحيد الاخير اهو.
يعني هما ثلاثة.
ثلاثة الموضوع ده احنا عملنا كده. دي حاجة تقدر توقف بوز برضه. بلاي.
بوز بوز وبلاي.
دي هتشتغل مع حضرتك صح؟ لا هعمل بس الانترفيو، لو حضرتك تستناني دي عشان فك البتاع ده واركبه تاني بعد اذنك. لا استنى هيثم استنى عشان كله يعني شغال بس شوف عامل مش عارف ايه فيها من كده. شوف فيها من دي عشان تزود. بس لا
دي اخر سلايد دي مش موجودة خالص في البرزنتيشن دي زيادة.
الحمد لله انا طلعت في اخر سلايد. هو هيتعمل بريزنتيشن
يعني
زي الماك. الماك بيبقى كده.
طب خلينا نطلقه كده نشوف. خليني طب انا اجرب عشان ايه.
طيب هم نشوف على بس انا بقى على الملأ.
معلش بس اشوف
انا كده
على
فوق
فوق.
انا كده فوق واحد.
وانا اغيره من هنا.
بتغير حاجه من هنا. حضرتك تحب تغير هنا؟
لا
ماشي واحده واحده بس عشان هي
لسه لودنج ولا ايه؟
لا مش لودنج، كل سلايد والثانيه يعني. دوس واحده بس قبل بس.
طب انا بس كنت عايز اروح
الفيديو
للفيديوز دول مش مهمين.
حاجه انا لهم بس هي دوس واحده عشان يبقى انجز، لانه لو ندوس دوستين
ماشي بيهنك
بيلاج يعني لما ندوس دوستين
خليني بقى العب انا فيها. فهنا
بالظبط. اوكي
بتاخد وقت برضه.
بس احنا الحاجه خدنا بالنا منها.
ايه؟
كويس. احنا هنخلي دي دوبليكيت
يعني
مش بريزنتر عشان الفيديو يبان اون توب. يعني هخليها كده مش هخليها بالشكل التاني. ليه؟ عشان الفيديو ما كانش باين اون توب، اللي هو الميديا بلاير اللي احنا عملناه ما كانش باين اون توب.
انت هتدوس هنا.
مش هات اوكي. ليه؟
هو ما فيهوش بلاي يعني، دي صورة
طيب
صورة
ثانيه جرب
حتى
حاجه في فيديو 2 كده،
حتى دي صورة بس.
يعني مش عايزين نشغلها.
يعني دي
طب
صورة،
احنا ممكن دي بس اللي نشغلها ودي ما نشغلهاش
ولا دي ولا دي، يعني نحط الصورة بس خلاص. يعني
أصلاً؟
خليني
اسهل من الاول كنا عملنا
لأنها مكياج سيني. واخد
انا
بالك؟
هاخد حضرتك، واخد الصوره، انا هاخد الصوره الاولانيه بس الاتش دي عامل لينك مش عارف
الإيه؟ سيبها كده وخلاص.
ما هي كده مش هتبان الفيديو ده هناك، فانا هعملها الاول دلوقتي بس عشان اقدر اشوف الفيديو. خلينا نشوف الفيديو اهو. مش عايز دي صوره اشغلها، هعمل برنت سكرين، هاخد الصوره احطها هنا يبقى اسهل من يعني الموضوع ده. دي كده
هي كده.
ماشي. برنت سكرين
Hello, how are you? Hello, Charles University to meet you.
Mongolia.
Have a good trip.
Yes, thank you. Just wanted to check how the systems work.
Yeah, I'm trying to check my videos. You know how that
Videos are always an
Hey.
issue, isn't it?
Yeah. Because I put them all on Mac, and there's always some conflict with PC.
Yes.
ناخد دي صوره.
So are we supposed to use this for?
This is
Pointer.
a pointer. You have to press down here, and then you move the slides from the up and down, or maybe if you want to.
لا بس ده لازم نوصله، انا بسأل الاول.
It has to connect if you want to move the slides.
I don't recommend this because I need you to be close to the microphone. So it's better to stay here.
Yes. Okay. Yeah, that's straightforward enough. Thank you.
Thank you so much.
No, say,
I just throw that in.
تمام.
طيب الأخيرة بقى هي الفيديو بقى.
الأخيرة دي سيبها دي كده زي ما هي، مش هحركها.
ماشي.
عارف ليه؟ لأن هي باينة.
خلاص اوكي.
فاهم ازاي؟ خليها كده.
تمام. احنا كده
يبقى فاضل لنا واحدة بس.
الأخيرة دي هنخليها فيديو زي ما هي، مش
وريها لي كده. طب وريها لي كده.
Persuade some of your colleagues that it's possible.
دي تمام. دي هتشتغل الفيديو حبة. انا مش مشغلها هنا، مشغلها لا مش مشغلها، دي حاجة تاني، دي صورة تانية، صورة ده مش اصلا هو مش دوبليكيتد كده. يعني نخليها زي ما هي. لا احنا كانت المشكلة هنا، سوري انا اسف.
كان في هنا دي
يعني دي المشكلة.
كده دي بتشتغل ولا مش بتشتغل؟
تشتغل. زي ما الطريقه الثانيه، الطريقه الاولانيه.
انت مستني ايه؟
انا مستني انه المشكله ان هم عاملين ميديا سيرفر يسجل، مستني عشان عايز اعمل ستارت البتاع ده وابدا
طب شغل دي كده عادي ولا؟
بس نشوف. في اصلا دي كانت دايره بس خلاص. أيوة. ماشي، تمام.
دي الوحيدة اللي هعمل فيها كده.
هنشوف بقى
ماشي
خلاص.
شغال والتانيين شغالين ها؟
التانيين دول شغالين هناك أهو. شغالة شغالة
تمام. انت
كده
انت
هيبقى بوز.
ده انت بتعمل
من هنا او من هنا او دوست عليها برضه هتبقى اوكي. نفس الكلام.
ربنا يسلمك.
ان شاء الله خير.
شكرا.
العفو.
حاجة تانية؟
لا ان شاء الله كله خير.
سيد؟
ما تعملش بريزنتر فيو.
انا ما بحبش اصلا اشتغل بيه. الموضوع الموضوع عندنا تقريبا اجازة.
يتسجل. جرب برزنتيشن تاني. شوف بقى المشكله في
بزنس
احنا شغالين بس هو الميديا ده حاسس ان هو متقل لي الدنيا سن تشيك في دي كمان. ممكن يكون البرزنتيشن التانية هي اللي تقيلة.
طبعا لما يكون بيعرض حاجه لايف وانت تعمل لايف ويب ستريمنج كده يبقى عيب على السي في. انت قصدك كده؟
بس انا عايز اشوف لحد اي اكستنت العيب ده. بقول العيب ده دي مفيش فيها مشكلة.
هيبقى العيب انه يقف تاني ولا العيب انه يطلع لايف؟
الاثنين، هو ده
الاتنين؟
بروسيسور واحد.
اوكي.
يعني احنا هنخلينا كده ماشيين
ماشي.
ميلاك سن عشان كده بقول خلينا يعني نجرب، لو حصلت حاجة نبقى
اوكي.
بس
انت
نخلينا
عندك حاجه تانية رانينج نقدر نقفلها ولا مفيش؟ انا السي في مركز على الاثنين دول بس مفيش حاجه تانية.
ان شاء الله مفيش.
ان شاء الله.
هو الكاميرا بس دايما اي كاميرا بتاخد
دايج.
لا بتاخد كميه كبيره من الكاش ميموري في المطلق يعني.
اوكي.
اي كاميرا بتاخد كاش ميموري بس anyway
طيب.
احنا لحد ما شغالين.
طيب احنا اول سيشن 3 محاضرات انت خدتهم ما عدا رشاد بشاره لسه مش كده؟ لما يجي ان شاء الله.
بس انا مش هعمل بريزنت فيو لانه بيعمل الحمل اكتر يعني
اوكي.
انا هخليني كده
اوكي.
يعني.
ماشي.
تايمر صح. بس تايمر هبعته لك حتى.
احنا مش عاملين ستارت اللايف سيستم لسه مش كده؟
لا ستارت شغال مش عايز اوقفه بقى.
طيب لا خلاص ماشي.
هو ده اللي مش شغال عليه؟
خلاص انا ممكن ابقى اعمل له تريم بعد كده.
انا هشوف هناك طالع عامل ازاي
بالظبط كده. معلش البطارية بتاعته عشان
منفصل. شوف لو
في حاجة تانية شغالة.
هو جوجل كروم. انتي مالوير.
عندك مالوير؟
انتي مالوير ولا اللي بياكل.
ممكن تكون.
احنا اونلاين مش مضمون الموضوع. احنا كده يعني
طيب كده هنشوف الصورة
comprehensive،
أخبارنا إيه.
بس انا
مم.
بقلق لما بيبقى في لاج كده عشان ما يبقاش حد متعطل. بس هبعت لهم التايمر عشان يبداوا يظبطوا.
أوكي. أنا زي الفل.
اول حاجه 15 صح؟ اول حاجه 15. في 15 وفي 5 انت عندك الاثنين. مش فارقه معاك حاجه بقى، انت خليك واقف يعني، خليه لما يبقى اعمل ستارت تاني. فاهم قصدي؟ اكنه بيعد لحد ما نبدا. لحد ما نبدا.
المهم يعني وخليها كونتينيوس لغايه الساعه 6.
مش هنقدر نلعب اكتر من كده.
بس لا برافو عليك.
بالظبط كده، ده لسان حاله.
مش فاكر هتلاقي كله على خبراتك. انت السبب في كل
فكرة حلوة. استبعد
انت عندك كتير
دي
تطلع حفله.
لا انا مش حافظها.
لا ده فظيع. بسم الله الرحمن الرحيم.
لا لا هو
شغال على طول. تسلم.
Hello, check.
يبقى شكلها صح. دخل الحته دي فقط.
بسم الله الرحمن الرحيم. طول عمرك كنت عارف التخيل بس اللي بتعملها. بسم الله الرحمن الرحيم. The Peripheral Vascular Disease Working Group of the Egyptian Society of Cardiology starts its meeting number 6. All over the previous 6 years, we have done rotatory conferences. The first 2 years, the president of the group was Professor Dr. Ahmed Awad Tahir. We have done a great effort along the course of this journey. I have had the presidency of the group for 3 years. And I have to offer my great thanks actually to my dear friend, Professor Dr. Ayman Saleh, who is not yet here, because he was the cornerstone of all the activities of the previous 6 years. And now the current president of the working group is Professor Dr. Nabil Farah, Professor of Cardiology at Shams University. And I leave the stage for them to welcome you.
بسم الله الرحمن الرحيم. طبعا في الاول بشكر دكتور رضا من الاول خالص هو اللي رشحني ان اكون بريزيدنت للوركينج جروب ده، بالرغم ان انا actually I'm not doing peripheral intervention، انما I like interventions in general, and to be a president of a working group يعني مش شرط ان انت تكون بتشتغل نفس الشغل، انما يكون عندك الايدياز ان how to organize and how to arrange for a conference, applications and things like that. طبعا بشكر الدكتور رضا على انه قبل ان هو يبقى chairman of this conference. احنا we did a lot of effort يعني to get this conference in this shape. بشكر يعني شكر بقى خاص للدكتور عمر الفاروق، لان هو اللي قام طبعا بمعظم الجوب regarding البروجرام واختيار الليكتشرز والسبيكرز واتمنى ان طبعا الكونفرنس يكون على المستوى اللي احنا يعني بذلنا المجهود اللي اتبذل من اجل الكونفرنس ده. دكتور عمر برضو يدينا بس فكره كده عن الكونفرنس اللي هو النهارده وبكره والبروجرام وازاي is going to work today and tomorrow.
Bismillah ar-Rahman ar-Rahim. I would like to welcome you all to our PVD Congress, and I'm very happy to work with Professor Rida Aiso and Professor Nabil Farag. I have tried as much as I can to collect the best scientific materials that we are able to have in 2 days. And the main task, which we all the three agree, is to concentrate on the junior staff in order to learn as much as they can from the tips and tricks. There is a unique advantage of this Congress that it is being live broadcasted over the internet. So you can listen to the lecture today and tomorrow. It will be live recorded on YouTube, and even you can put your questions and answer 1 and 2 days after you have heard the lecture. And I think this is a big advantage for you to have, let us say, a live document over the next 2 days. We have tried to introduce new technology, and you will see the hybrid room technology. We tried to introduce the best interventionist in Egypt, and that is what I hope that you will gain out of this Congress. We would like to stick on time regarding the presentation, and I hope you have a nice time with the Congress. Thank you. So the first session will be moderated by Professor Ali Murad, which is starting at 5:10. Professor Ali.
بسم الله الرحمن الرحيم. طبعا نبتدي بالشكر للجنة المنظمة على دعوتنا للميتنج ده. The first speaker is Dr. Hisham Basnoun, and we'll talk about what is new in Kifa and Kifa. Dr. Hisham Basnoun. طبعا الاستاذ الدكتور هشام باسم يعني is one of the reference and is one of the topics in vascular and endovascular surgery.
Thank you very much for this nice introduction. I thank the organizing committee for inviting me to talk today. I have been assigned the task of talking about endovascular aneurysm repair. And it's not just limited to infrarenal aortic aneurysms, because the field has progressed very dramatically over the last 10 to 15 years. I dare to say that to get involved with complex aortic reconstruction with endovascular techniques, it requires a very high skill set and a lot of understanding regarding the pathology and imaging and planning for these procedures. So when we look at endovascular therapy for aortic disease, it spans many conditions. We started off with infrarenal and thoracic aneurysms, isolated infrarenal aneurysms, maybe involving the iliacs or not, and thoracic aneurysms isolated to a segment, and now the technology has extended to thoracoabdominal aneurysms, even arch aneurysms, acute and chronic complicated dissections, acute uncomplicated dissections in which we find that there is high risk for progression. Namely, there are certain criteria: a large false lumen, flow within the false lumen, and a large entry tear. In some settings now, in Europe and the USA, there are dedicated teams to treating ruptured aortic aneurysms with endovascular repair. And now there are devices for isolated common iliac artery aneurysms. So you can see that this is pretty much a very large number of conditions that are covered with endovascular therapy. And perhaps there are a few cases that are not amenable to endovascular treatment, such as ascending aortic dissections, type A dissections, ascending aortic aneurysms, Marfan patients, and infections in the aorta. There is no doubt that endovascular therapy is much better than open repair, especially in the first 30 days. The mortality is about 50% or less than open surgery. However, the long-term survival of these patients, when you compare open versus endo, is the same after many years. So the benefit is gleaned during the first 30 days. Why? Because there's decreased blood loss, certain shortened length of ICU stay, lower incidence of pneumonia and renal failure, significantly lower mortality and paraplegia, especially in patients with thoracoabdominal aneurysms, very excellent long-term patency, and excellent freedom from aneurysm-related death. Whenever you put a stent in an aneurysm, you wonder what's going to happen to this aneurysm long-term. Is it going to rupture or not? But the fact of the matter is that the results are consistent and long-term well. So when we look at EVAR, TVAR, FEVAR, which is fenestrated endovascular repair, there are a lot of challenges and tasks. It's not like putting a stent in a stenosis. No way. There's a lot of pre-intervention planning. You have to be comfortable with the device. There are a lot of devices. You have to be comfortable with measurement of the device, the component lengths, etc. And planning, I would say, is the big battle. If you plan right, 90% of your battle is won. And then how to manage complex situations and get out of trouble. Because, you know, if you're an interventionalist and all you do is catheter-related work, you have to know how to get out of trouble. And of course, your vascular surgeon is always there to help. You might have suboptimal iliac access. You can't get the device. These are large devices, anywhere between 18 to 24 French. There is sometimes a lot of tortuosity, as you can see in the CT scan, angulated and short infrarenal necks, and so on and so on. And then you have to make sure that you have a good seal, or your operation is a sham operation. Furthermore, if you're doing fenestrated grafts or juxtarenal cases, you have to make sure that you're going to preserve vital aortic branches. You have to take certain precautions with anesthesia. I'm not going to get into that, to prevent paraplegia. Have to limit contrast administration, radiation exposure. And obviously, you shouldn't leave the operating room with a type 1 endoleak where you have still an endoleak at the proximal distal fixation site. And that basically pressurizes the aneurysm, and as if you've wasted a whole stent graft for nothing. Now, if you look at the variety of endografts that are available, there are a multitude of them, and they now have been specialized to allow for suprarenal fixation so that there's no migration of the graft. Some of these grafts have low profile, like the Cordis, which has reached 14 French. There are also very interesting novel devices that inflate a balloon inside the aneurysm sac with two limbs that are attached superiorly by actually this balloon, so that you prevent endoleak. This graft has rings in it to prevent migration and endoleak. And then, as you can see here, the AorFix, this is a stent graft that allows for placement in very high angulated necks. Then there is a gamut of stent grafts that allow for suprarenal fixation and preservation of the renals. These are particularly suitable for patients who have juxtarenal aneurysms with no infrarenal neck. And there are a variety of these grafts now that are available off the shelf. Especially the anaconda graft. If you can look at the picture here, you can see the distribution of the location of the renal arteries and the spermocenteric artery are generally in one location, so you have a variety of grafts that you can pull off the shelf that can help you without custom fitting every patient. So now we've moved up to the suprarenal aorta, and from there you can go up to using fenestrated grafts. Some of them have preloaded catheters so that you can even deal with aneurysms involving the renal arteries, the superior mesenteric, and the celiac arteries. This is a fenestrated endovascular graft by Cook, and it has fenestrations for all 4 vessels, and it is composed, as you can see here, of a superior portion for the suprarenal aorta that has the fenestrations, and infrarenal components that extend into the iliac system. Obviously, these grafts are worth maybe a BMW X3, $500,000, but you know, it is worth it because the alternative of open surgery leads about a 20% mortality and paraplegia rate. There's also a new graft called a T-branch Cook device, which is also off-the-shelf device, and it offers versatility such that you can cannulate the branches from above and enter into the celiac, SMA, and renal arteries. Again, you have to extend this to the iliac arteries upon finishing the procedure. Moving up, you're going to find that there are now stent grafts that allow for preservation of the subclavian artery if you have a type B dissection and you want to preserve the subclavian artery, which is not usually the case, only in specific instances. And you also have arch endografts with 2 branches for the innominate and for the left common carotid. So experience with these grafts is evolving. I can tell you that a recent publication for arch endograft shows about a 10 to 15% complication risk. Again, it remains to be seen if these are going to be better than open surgery or not. I guess one of the major advances for using these very complicated devices is using adequate or superior imaging so that you can position the stent graft exactly where the orifices of the visceral vessels and renal vessels are. What is called fusion or overlay imaging technology. The new hybrid suites actually have this capability with DynaCT such that you can export the CT scan 3-dimensional reconstruction to your hybrid imaging unit and overlay the bony structures, so you basically have the entire aorta overlying the spine with the precise positions of the visceral vessels so that you can position your stent graft very, very nicely and achieve success in cannulating the branches. As you can see here, for example, in this image, the rings, the golden rings are the stent graft, and the white rings are the visceral vessels. This is a hybrid suite. Obviously, it is essential for doing all these aortic cases, I believe, because sometimes you need cut downs and you need a good imaging system. The cardiac cath lab is very challenging to do these cases because of the low image field, the small image field, and it does cause a fair amount of irradiation and contrast usage. Our stent grafts, our fenestrated stent grafts with branches, are they durable? There is a risk, obviously, that these branches may dislodge, but with adequate follow-up, you can detect these problems and position bridging stents to prevent any kind of endo leak and allow for perfusion of the visceral vessels. In places like the Cleveland Clinic, where now they've done more than 1,500 fenestrated stent grafts, the results are outstanding, especially with paraplegia, and it's usually less than 5%. Some tips here regarding the problems that we face. This is a patient who has a very angulated neck with very bad iliac axis. It's very difficult to get into the left iliac system. One of the options here is to perform an aorto-iliac iliac graft and perform a fem-fem. In some instances, one is obliged to either place an external conduit to the proximal common iliac artery because the external iliac arteries are so small, or you can do an endoconduit whereby you can actually place a covered stent graft inside the iliac system and forcibly expand the stent graft so that you can allow up to a 24 sheath to go into the aorta. Here's a case where actually this is not the right case. They've mixed up my slides, so let's see here. Please ignore the top slide. This is going to come later. This is a patient who actually had, I had the picture of the infrarenal neck here. It was very angulated and short, the infrarenal neck. And if you look at this plain film here, you can see a 6 centimeter by 32 millimeter EXL stent. This EXL stent was used to buttress the infrarenal stent graft, and that helped prevent the endoleak. And you can see here the completion arteriography with the uncovered stent at the top, and the renal arteries are well visualized. Here's another patient who had a complicated subacute type B dissection, and here you can see the dissection starting just distal to the left subclavian with a very large false lumen. This patient had constant back pain, and a stent graft was placed very proximal to cover the left subclavian artery. And this is the post-op image of the stent graft. One of the important things about dissections, type B dissections that need treatment, is that you should err to the side of covering the subclavian artery so that you can cover completely the proximal entry tear. And secondly, you should not extend your stent graft far down to cover the celiac or the SMA, obviously. If you do have fenestrations that are distal, these can be life-saving because they allow for retrograde perfusion, as you can see in this image of the visceral vessels. And it's very important upon completion to demonstrate the visceral perfusion. So fenestrated and branched stent grafts are a great solution for complex aortic pathology. Obviously, they're costly and need to be custom designed in the majority of cases. So there are practical options that are available to us that we can use. These are called chimps or chimneys and snorkels and periscopes. If I can have a few more minutes. This is an example of an arch aneurysm that has been treated with a stent graft and multiple chimneys that are inserted retrograde from the carotid arteries and the subclavian arteries to allow cranial perfusion. This is what's called the chimney because the flow is going up. Periscopes are also used if you have a thoracoabdominal aneurysm. These periscopes are introduced into the visceral vessels prior to deployment of the graft. It requires Viaband grafts that are flexible so that they can mold to the origin of the vessel and the aorta. Snorkels also are used for renal vessels, and the results actually of using snorkels together with a regular stent graft are as good as fenestrated grafts in recent studies. Here's a patient. You saw the first x-ray of a patient with big thoracoabdominal aneurysm. I just want to show you that this is a type 4, and this is the position of the stent graft. You can see that there is a very large aneurysm, a thoracoabdominal aneurysm extending to the celiac artery. And the distal extent of the stent graft was of concern to us because it could cover the celiac. So both the celiac axis and the superior mesenteric artery were cannulated from the groin, and sheaths were placed in these arteries before deployment of the stent graft. We had to eventually place a chimney in the celiac axis, that you'll see here in this last slide. So that allowed for celiac artery perfusion, in spite of the fact that the artery was covered. And then finally, the hybrid approach, which is very useful if you don't have all this fancy technology and you only have regular stent grafts, thoracic and EVAR. This is a patient who had a type B dissection starting in the aortic arch and became aneurysmal over time, underwent deep branching of the visceral vessels, a right common carotid to a left common carotid, a left common carotid to a left subclavian, with ligation of these branches, and then you can put the stent graft all the way up to the innominate artery and extending distally. In the very last slide that you see on the right-hand side, the patient had also this aneurysm extending to the thoraco-abdominal segment, required retrograde deep branching from the iliac artery to the visceral vessels, thereby disconnecting the vessels from the aneurysm, and then placing stent grafts all the way down. So in conclusion, I think that we're entering an area here where operative therapy for complicated thoracic aneurysm, thoraco-abdominal aneurysms, suprarenal, juxtarenal aneurysms is going to fade out. There are a lot of devices that are very innovative and allow the interventionists to treat these patients with excellent safety. Obviously, it's minimally invasive, so it's very preferable for the patients. Clearly, the fenestrated stent grafts are still problematic because of cost and the time needed to design those. And then we have alternative techniques that can help us get through these difficult cases if these very complex devices are not available to us. Thank you very much.
واضح ان العمليه غير عاوزه انجي سوبر، عاوزه اكسبيرينس كامله، وعاوزه اطمئنان من الفلوس بحيث بناء عليه مش هينفع ان واحد يشتغل على تركيب ثاني يشتغل على تكسير و95 لكن يبقى على مستوى الوطن كله في مكان واحد في هذا التجهيز وفي شخص واحد له عدد كافي من الحالات بحيث ان اكتيفيتي اكسبيرينس تجعله يبقى مع ريزالتس معقوله. هذا الشيء اللي بيخرج وقت انا في العمليه ويبقى لانشاء السيستم او تكوين اكسبيرينس كافيه لان مصر على مستوى مش تبقى في شغلانه كده.
دي طبعا دي نقطة مهمة جدا. لو حضرتك تبص على أوروبا وألمانيا وحتى في أمريكا في specialized centers for treating thoraco-abdominal aneurysms. كل الحالات بتروح جامعة A or B or C. فما عندكش أولا الشركات عموما ما بتديش الفينستريتد ستنت جرافts دول لأي مستشفى. This is number one for safety reasons. فطبعا مهم جدا ان يبقى في localized or high volume centers الاكسبيرينس فيها تبقى concentrated لان ده بيحسن ال results. We all know that results are related to volume for كل specialty. But this is one thing. The other thing too is that المفروض ان يبقى في foundations تساعد الناس اللي هم مش قادرين يدفعوا الستنت جرافts دي انهم يعني they contribute to these patients whether it's the societies او industry او الجامعات كله يبقى عنده foundation واحده تقدر انها تمول الستنت grafts دي for people who cannot afford it. philanthropy الناس لازم تدي فلوس زي بالظبط بيحصل بره.
Thank you, Dr. Richard. I'd like to just very small questions and quick answers.
Sure.
Cost as regards surgery versus endovascular graft.
In relationship to infrarenal repair or fenestrated or as a whole.
So let us say an endovascular graft for an intrarenal aortic aneurysm versus surgery. Cost.
The cost is a little bit higher than open surgery in financial analyses abroad, but not that much. But you have to also consider the quality of life of the individual, quality of life years. So that if you, for example, have an open procedure and you stay in the ICU for 4 or 5 days and then you recover in about 4 to 6 weeks, that's money. So cumulatively, it balances out.
Number 2, what about the access side? If you have a problem in introducing your material from the femoral region, what do you do?
As I mentioned here, you have two options. First of all, obviously, you have to anticipate the problem by pre-planning. If you're going to use a device that needs a 20 or a 22 or a 24 French sheath, you have to make sure on the CT scan before you go in that the iliac system will take that device. If it's too small, then you can put a conduit, which needs a retroperitoneal incision, or you can put a covered stent, as I mentioned, and forcibly dilate the iliac system.
Have you ever experienced an intra-abdominal leak during implantation of the endovascular?
No. No.
This great improvement and advances in endovascular intervention, whether there is still room for open surgery in certain conditions, or most of the problems can be made with endovascular.
Yeah, as I mentioned, if you are living in an environment where you have all the tools, the number of open surgeries becomes very few. Except in specific instances, as I mentioned, a young patient who has Marfan's, for example, if you put a stent graft in this patient, the rest of the aorta will continue to dilate, and he may develop an endoleak. Patients who have ascending aortic aneurysms, although I can tell from how the research is going that eventually even those will be endovascular used with TAVR. So there's an evolution. Patients also have aortic infections. These are patients with mycotic aneurysms. You don't want to put a prosthetic device inside the aorta.
Just one question. The incidence of paraplegia with these devices in the ascending aortic aneurysm versus surgery, which is more.
Surgery, obviously, there's many problems associated with open repair, except in very specific centers, maybe 1 or 2 in the world, where they have a paraplegia rate of less than 5%. Paraplegia usually occurs when depending on the length of coverage of the thoracic aorta. So if you're going to cover all the way above the 6 interspace, you have to take certain precautions to prevent paraplegia. One is a functioning spinal fluid drain that works very well so that you can drain the spinal cord, because edema does happen from ischemia, optimizing pressure so that you can improve the perfusion of the spinal cord. In general, with all these precautions, the paraplegia rate is about 3 to 4%. So it's not that much. And the reason is that when you cover the intercostal arteries, you're still maintaining perfusion through the collaterals. But when you open up the aorta during an open repair, you siphon out the blood flow.
Thank you very much.
You're welcome. Appreciate it.
And we're going to look on some instrument angiography, widely applicable and produces durable results.
I'd like to thank the organizers for inviting me here. It's always a pleasure to come to Egypt, so thank you very much for the invitation. Okay, subintimal angioplasty is widely applicable and produces durable results in critical limb ischemia. Now, when you have critical limb ischemia, basically, as we all know, the limb needs more blood for the foot to be saved. And all revascularization techniques can achieve that: bypass surgery, intraluminal, subintimal. So, and broadly speaking, limb salvage rates are similar for all these techniques. So where is the difference? The difference, in fact, lies in the indications. And this is where subintimal angioplasty makes a big impact, because there are much wider coverage of indications. Here's examples. You can see aortic occlusion extending to the iliacs, flush occlusions, SFA, following recanalization, reconstitution of the trifurcation, and also recanalizing long tibial occlusions. None of these techniques can achieve all these aims. So I think this is where this technique is a big winner. The technique is applicable in iliac occlusions, profunda, femoropopliteal, and tibial occlusions. So we can start higher up. Common iliac artery occlusions. Usually we prefer the contralateral approach, which is easier because re-entry into the external iliac is almost always possible. The reason being that as you extend further down into the arterial tree, the intima gets thinner and therefore easier to break. If you take the opposite view, when you approach it retrogradely, you find that the intima is quite thick and tough, and therefore a dissection ensues right into the aorta, and that can make re-entry into the common iliac origin quite difficult, and this is where the re-entry devices come in. And of course, we would use, generally speaking, if we were going to stent, we would use balloon expandable stents, because the intima is quite tough in order to make an impact there. So here's an example of a common iliac occlusion that was successfully treated through the contralateral approach. Another example, common iliac occlusion. And this was not an adequate result with just the balloon, so we've used a balloon expandable stent. When we come to the external iliac arteries, again, the contralateral approach is the preferred approach, and re-entry is almost always achievable. And once again, if you use the ipsilateral approach, you may find that your dissection is going up much further, and you may require a re-entry device. In this situation, we prefer, if you're going to stent, to use a self-expandable stent in order to accommodate tortuosity as well as length of occlusion. This is the publication we made some while ago, where we used to approach ipsilaterally, and you find that it's difficult to break back in, so we come contralaterally, basically do a dissection from the two approaches, and because there is common ground in the dissection, you can usually find the way back in. But nowadays, almost exclusively, we use the contralateral approach. So here's an external iliac occlusion, and following a successful recanalization, and the same thing on the left side. The technique has the advantage of reconstituting bifurcations and trifurcations. In this case, there's a common femoral occlusion extending into the profunda, and the SFA is occluded, full-length occlusion right to the popliteal. And by having the contralateral approach, you can make your loop here, extend the dissection, and quite often it may go into the profunda. You dilate that, and then you look for the origin of the SFA, which you can usually find by probing with a wire, and in that regard, you can reconstitute the bifurcation. Now, this is something I've always emphasized, and I'm going to do it again. The technique has got the great power of remodeling, and here's an example in an iliac occlusion. Somebody we treated here, left common iliac occlusion as well as the right common iliac stenosis, and you can see this sort of result for people who are experienced will immediately say this is a terrible result. You've got to put a stent to make it look nice. We didn't put a stent, and 1 year later the patient comes back and this is what it looks like. Absolutely beautiful, no symptoms at all on the left side, and in fact it was the right side that was the problem, which we then recanalized. Regarding the femoropopliteal territory, there are great advantages to this technique. You can do long occlusions, flush occlusions, and common femoral bifurcation, which you've seen an example of. You can deal with moderately calcified lesions, occlusions with underlying diffuse disease. You can even deal with long diffuse stenoses rather than occlusions. If there is a large proximal collateral, again, it's not too difficult to dissect, whereas with an intraluminal approach, you would really struggle to enter into the occlusion. And with perforation, there's a complication. You can find alternative dissection. So here's an example of a flush occlusion extending up to the adductor canal level, and this is following a dissection. And you can see that the artery was reconstituting here, but we had to extend the dissection further, and there is still a dissection up to there. You can see that the loop is quite wide into this wide dissection, and then suddenly re-enters, the loop narrows, so re-entry has been achieved, and this is the successful outcome. Inevitably, very smooth, beautiful results, which is not what we look for. We look for good hemodynamics rather than what it looks like, but as it so happens, it looks nice as well. Very diffuse long stenosis. We nowadays dissect these as well. The whole length of this will be dissected to achieve a result like this in order to achieve durability of the procedure. This is in the SFA, again, the power of remodeling. Patient with an SFA occlusion, clearly approached with a dissection procedure. There was a stenosis here, and we recanalized this, and you can see what it looks like. 1 year later, beautifully remodeled. It looks as if there was never been a disease there. And in fact, the patient's symptoms were due to this stenosis in the distal SFA, which we then angioplasted. The technique works very well in tibial arteries. You can deal with long occlusions, multiple recanalizations, and you can also reconstitute bifurcations and trifurcations. The only technique that can actually do this, I believe. You can also reconstitute the pedal arch, but I put this in brackets. I think you have to really exercise this with caution. So here's a long occlusion of the anterior tibial artery following successful recanalization. Occlusion of the posterior tibial, again reconstituted. And here's again patient with critical limb ischemia, and you can see all the vessels are occluded at some point. And by this approach, you can reconstitute the bifurcation, thus taking care of both vessels that actually go all the way down into the foot. And in a similar manner, if you've got a popliteal occlusion that is extending into all three vessels, and all three vessels are available in the foot, and it would be a shame not to catch all of them. So here we are, reconstituted the full trifurcation. Just another quick example, patient with critical limb ischemia, all vessels occluded. This is following the posterior tibial recanalization, then the anterior tibial, and finally making the communication to the peroneal artery, and this is what the foot circulation looks like following the recanalization. Just another quick example of something similar. This is following a successful angioplasty. Why do we need to recanalize multiple vessels? These are the reasons. You get improved total perfusion of the foot. If you've done any proximal angioplasty, obviously that is going to benefit having a 3-vessel runoff, having faster flow through 3 vessels, and also it's an insurance against blockage. So if one of your runoff vessels blocks, the other one is still there. The aim of these procedures are generally to create the best hemodynamics. So if there is 2 or 3 vessel, 2 or 3 level disease, we try and treat them all if we can. So we would do an iliac angioplasty, femoral popliteal recanalization, and tibial recanalization all at the same time in order to achieve the best hemodynamics. Because our belief is that if you improve the inflow, that complements the distal vessels, you get good inflow that keeps the distal vessels open. Similarly, if you've got good outflow, this complements any proximal angioplasty by enhancing the flow. So here's another quick example. Patient with iliac occlusion on the right and external iliac occlusion on the left, and then a full-length occlusion of the SFA extending to the popliteal area. Clearly, this is challenging because both iliac systems are occluded, so you can't really do a groin puncture. I guess you can do it here, but then you won't be able to treat the other lesions. What we did was approached it through the brachial artery in order to deal with the external iliac occlusion as well as the SFA, and this was the final outcome: external iliac artery angioplasty, SFA recanalized in this way. What about results? Here's early results, unfortunately rather small numbers, but what we consistently see is very high limb salvage rates with these procedures. This is a little bit more recent results, again not big numbers, but you can see respectable salvage rate results. This is perhaps a somewhat larger study, 2008. Secondary patency 76%, and 50% at 3 years, but limb salvage rate 75% at 3 years. And these are some meta-analyses of somewhat large numbers. Again, they all come up with a reasonable consistency of good limb salvage rates. This is an interesting study I found, published recently by, would you believe, a medical student who actually surveyed 129 studies, of which 9 studies, or 11 were suitable for the analysis, 9 retrospective, 2 prospective, about 1,500 limbs over a 15-year period. And again, what they found is high technical success rate and very respectable limb salvage rates. Another good study also from Ireland by Sultan, observational study of over 1,000 patients with peripheral vascular disease, of which 206 had subintimal angioplasty, 128 had bypass grafts, and all patients had critical limb ischemia, and this is what they found. Sustained clinical improvement was better with subintimal angioplasty. The rest of the results were fairly similar, and this is at 5 years. And their conclusion was that subintimal angioplasty is poised to bring about a paradigm shift in the management of critical limb ischemia. The authors and the operators are in fact vascular surgeons. So I'd like to conclude by saying that subintimal angioplasty really is now an established procedure, or should be. Limb salvage rates, very, very respectable. It is the first line treatment for critical limb ischemia. There is, of course, a learning curve, but I believe most people can learn this technique without much difficulty, and it has the potential to make a major impact on critical limb ischemia. Thank you very much. Bang on time.
Shall we open the floor for discussion? 5 minutes. Wrong. Actually, 2 minutes.
Thank you very much for very elaborated lecture. My question, how much is the cost of the tools that you are doing something from an angioplasty? I think it is really unique, and I was impressed by the plan. Thank you.
Yeah, thank you for that question. My talk tomorrow is actually going to cover the technique of subintimal angioplasty, and I've got a slide that shows you the materials that we use. And last week I just went to one of ladies who does the ordering to just ask her, can you cost these materials for me? How much do you pay for it? And I myself was absolutely shocked at the cost. What we use is a needle, a standard Teflon wire, a hydrophilic guide wire, mini cath, so-called Bolia mini cath, one balloon catheter, and one simple inflation device. And the total cost was 76 sterling pounds, which is about 800 Egyptian pounds. That is the cost for the vast majority of the procedures that I do, about 90%.
I have a question regarding the type of wires that you use for the iliac and tendons. So you use a glide wire, 135 glide wire for tendons?
Yes, glide wire almost exclusively for all the procedures. The only difference is which one do you use. Of course, in the iliacs, sometimes you need the support and the strength, pushability if you like, because you're working in the opposite direction. So we would use a stiff hydrophilic guide wire. Most of the SFAs we use just standard hydrophilic curved wire. And in the tibial vessels, we use the 1.5 millimeter J hydrophilic wire, which is half stiff. So it has the stiffness between standard and the stiff.
It's an 035?
035, yes.
Okay, my second question to you is regarding your results. You mentioned hemodynamics. So I'm curious to know what your follow-up is. Do you see any difference, for example, between those patients who fail and those patients who don't, based on your duplex findings, your initial duplex findings?
Sorry, repeat the last bit, sorry.
So you do a subintimal angioplasty in the femoral popliteal segment.
Yeah.
And you're seeing the contrast flow nicely.
Yeah.
That doesn't tell you much about the volume flow or the peak systolic velocity or anything. So how does that relate to your long-term patency?
Well, I mean, that's a good question. And unfortunately, subintimal angioplasty and a lot of angioplasty procedures lack in good scientific data like the sort you are seeking. We're all seeking. These techniques have come in because they're felt to be good. But you know, in terms of critical limb ischemia, if you speak to our surgeons, they would not have it any other way. This produces extremely durable results clinically. We don't do any of the measurement studies that you're talking about simply because it's not part of a study and the finances are so restricted.
How do you follow these patients?
So, Jack, just to explain, please.
Sorry, how do you find?
How do you follow them?
The simple answer is we don't anymore, which is a very, very sad fact to tell you, but because of the financial constraints, our system doesn't allow follow-up patients. Sorry, thank you.
One quick question to Dr. Wasila, the one quick answer, the one answer from the table, then we're going to move to the next section.
Thank you, Dr. Michael. First of all, post-factum education, we are very glad to have a new Professor Raboya among us today.
Thank you.
It's an extension of the question of Professor Massoud. We should have an objective measurement in the eye of expanding oxygen or pressure oxygen just before and after to evaluate your success, your technical success. It could be much more. This is about the objective measurement. My second short question is about if you have a tip for beauty entry. How do you predict that this level will be improving, or you go with your group until you found it?
Yeah.
Or just a small extension, do you rely on another imaging, maybe the very scaling just work with ultrasound to tell you this is the weakest part, this is the evolution part, and you can go inside at this level?
No, for the last point, we don't really use, well, all our patients get duplex, and the aim is to, show the length of the occlusion and the chronicity perhaps, or rather the acuteness. Excuse me. If there's an acute occlusion, of course, we wouldn't intervene, otherwise it causes complications. In terms of re-entry, basically you need a loop in the hydrophilic guide wire, and use a twisting action in order to achieve re-entry, because as you know, all dissections go in a spiral fashion, and this is enhanced by that move. Yeah.
Last question, please. You mentioned because of the phenomena of remodeling, which is depending on improving our inflow and outflow from the artery, you don't use stents. If there is some cases in which you use stents beside the dilatation.
Yes, the only time we use a stent is when there is a significant recoil in the artery. So some vessels you recanalize, you've crossed the lesion, you dilate, but unfortunately the strength of the wall is so strong, it keeps collapsing. Then there's no other answer than to use a mechanical support. We use it in less than 1% of cases.
Okay, thank you very much, Dr. Ahmad. Now we have the third and last speaker in this session, Dr. Rashad Bashar, and he will comment on about the update on intra-arterial thrombolysis. Please, I would like the speakers and the audience to ask questions to keep the microphone not in front of their mouth, but not please, because of the blurring of the mic.
I would like to thank the organizer for inviting me to participate in this conference. Mr. Chairman, dear colleagues. Well, first of all, while we're getting this ready, I would like to ask you, who among the audience is familiar with intra-arterial catheter-directed thrombolysis? Would you raise your hands, please? Okay. I'm going to give you an update about thrombolytic therapy for acute limb ischemia. Acute limb ischemia that I'm going to address is the ischemia that's caused by acute embolism, thrombosis of native artery, graft thrombosis, or stent thrombosis. I'm not going to address acute ischemia caused by trauma or iatrogenic injuries or other causes. We're all familiar with the Rutherford classification of acute ischemia. Class 1 should be treated semi-urgently. Class 2 are very urgent. And Class 3, we usually offer major amputation. We depend mainly on duplex to diagnose acute ischemia and this underlying cause. This is a typical example of the sign that we've described, the pulsatility sign. We found the native artery that is occluded and yet pulsating. And we found this very telling that it is acute in onset and that it is caused by usually embolic material. The options for treating to acute ischemia are surgical or endovascular, catheter-directed thrombolysis, or pharmacomechanical thrombolysis. I'm going to focus on catheter-directed thrombolysis. There has been 3 major randomized trials regarding the comparison of catheter-directed thrombolysis versus surgery. They were all performed in the early 90s, and since then there has not been any major trials. So I'm going to go into some details regarding these trials. The Rochester trial in 1994, the thrombolytic for ischemia of the lower extremity trial, the STYLE, in 1994, and the thrombolysis for peripheral arterial surgery, the TOPAZ trial, in 98. The first one, the Rochester trial, 114 patients were randomized into surgery versus catheter-directed thrombolysis using urokinase. As you can see, the amputation-free survival was better for surgery as compared to thrombolytic therapy. However, going into the analysis of this group of patients, it was found that the deaths were mainly caused by operating on patients with significant comorbidities, which of course makes sense. The second major trial, the STYLE trial, 393 patients were randomized into catheter-directed thrombolysis or surgery. However, this trial has one peculiarity in that they included patients who had acute ischemia up to 6 months duration. So in the analysis, they were subdivided into 2 major groups: those who had the symptoms for greater than 14 days and those who had the symptoms acutely less than 14 days. For those who had the symptoms more than 14 days, the surgical group fared better, while those who had symptoms for short duration, the catheter-directed thrombolysis fared better. Now, this is the third major trial, the TOPAZ trial. 544 patients subdivided into randomized into surgery versus catheter-directed thrombolysis using urokinase. And comparing the amputation-free survival at 6 months, it was found that there was no significant difference between the catheter-directed thrombolysis group and the surgery group. However, looking at the major hemorrhage, it was found that there was a much more major hemorrhage in the catheter-directed thrombolysis group as compared to the surgery group. Now, I'm sure this is a bit confusing. This meta-analysis, which was published in the European Journal of Vascular Surgery in the year 2000, has summarized the findings of these 3 major trials. And regarding major amputation at 30 days, it was found that there was no significant difference whether surgery is used initially or catheter-directed thrombolysis is used initially. Regarding mortality at 6 months, again, it was found that there was no significant difference between surgery and catheter-directed thrombolysis used as initial line of treatment. However, regarding major hemorrhage as a complication of treatment, it was found that there is a significant difference between the surgery group and the catheter-directed thrombolysis group in favor of surgery. So there was less hemorrhage in the surgery group as compared to the catheter-directed thrombolysis group. This is a Cochrane review published recently, last year. It summarized 5 trials, including 1,283 patients, in whom a group had initial surgery as the first line of treatment, and a group had thrombolytic therapy as the initial line of treatment. And there was no significant difference in amputation or death between the 2 groups at 30 days, or at 6 months, or at 1 year. In the same review, they looked at the complications, and they found that stroke was more common in the thrombolysis group, major hemorrhage was more common in the thrombolysis group, and distal embolization was also more common in the complication group. So in summary, although there was no difference in survival and in major amputation, there was significant difference in the complication rate. And these are the recommendations of the clinical practice guidelines of the American College of Chest Physicians, published in year 2012. It states that we recommend surgery over intra-arterial thrombolysis as initial line of treatment, and this is a grade 1B recommendation, meaning that it's a strong recommendation, but evidence is based on only a few prospective randomized trials. That's regarding comparing surgery versus thrombolytic therapy. Regarding comparison of various thrombolytic agents, there has been no recent publications regarding streptokinase. It's really out. And this is caused by the known incidence of allergy and systemic complications such as hemorrhage. So there has been comparison between urokinase and RTPA, and this is an example of one of them. There is not much difference. And urokinase is not available in Egypt or in the States and in many other countries. Regarding the dose of thrombolytic agents, the most frequently quoted dose in the literature is half 1 milligrams per hour of RTPA. Here's an example of one randomized study which compared ultra-high dose of RTPA, that is 15 milligrams per hour given in 2 hours, aiming at achieving rapid thrombolysis, versus the low dose of half milligram per hour up to 48 hours infusion. In this particular study, there was no difference between the ultra-high dose and the low dose in terms of results and in terms of complications. But I can tell you that both those two doses have had a lot of complications. Now, this is our own policy, how we treat acute limb ischemia. Acute embolism, we offer patients surgery as a first line of treatment, except in selected patients in whom we offer thrombolytic therapy. Those are the patients with extensive distal thrombosis, in whom surgery will not have good results, and in high-risk patients with comorbidities that would not allow for safe surgery. In native artery thrombosis, we offer surgery or thrombolytic therapy based on individual setups of patients, depending on which artery is affected, on the duration of acute ischemia, on the extent of thrombosis, in particular distal thrombosis, previous history of chronic limb ischemia, and associated comorbidities and risk factors. In graft thrombosis or stent thrombosis, duration is important. Less than 14 days, we usually offer thrombolytic therapy in addition to treatment of the underlying culprit region. Surgery in selected cases, while in more chronic cases, we offer usually surgery as a first line of treatment and thrombolytic therapy in selected cases. And here is our policy regarding the thrombolytic regimen. We use RTPA. This is really the only agent that we use. Our dose is 1 to 2 milligrams per hour, up to a maximum of 100 milligram. The details of our technique could be summarized. Ultrasound guided access. We think this is very important because it allows one puncture in the anterior wall, which I think goes a very long way in reducing access site complication, which is an important part of the complications reported in thrombolytic therapy. We use purpose-made thrombolytic catheters. We use pulse spray technique and not infusion technique, and we think that makes a lot of difference in terms of effectiveness and time of thrombolytic therapy. We use duplex control, not angiographic control, because we believe contrast can be very harmful to ischemic tissues, can even be thrombogenic if the arterial tree is occluded with very sluggish flow. So we use duplex control, except sometimes in final angiogram to document end results. And the maximum duration of thrombolytic therapy is 48 hours. If the patient exceeds this period, we tend to offer alternate therapy. Using the policy that I just mentioned, we think our results are even better than the majority of the publication in the literature. I'm going to give 2 simple examples. This is a patient who presented with occluded stent, which was initially performed for popliteal artery aneurysm. And this is the initial angiogram, which will show complete occlusion of the distal femoral artery and popliteal artery. Of course, the stent is occluded. And this is an angiogram of the distal arterial tree in the popliteal and tibial region, which shows only collaterals. There are no patent arteries. This is a typical patient in whom surgery would be disastrous because there is no distal runoff vessels. This patient had thrombolytic therapy, and the first step is the wire crossing test. We test whether the thrombus is soft or not by passing a wire. The wire is made in the form of a loop to make sure that we are inside the stent rather than outside its walls. And then a thrombolytic catheter is inserted. This patient had continued thrombolytic therapy for 24 hours, at the end of which he had Doppler scan showed complete patency of the popliteal as well as the tibial arteries, and this is an image of the patent stent. Another example of a patient who presented with thrombosis of the left external iliac artery. She was an obese patient with a lot of comorbidities and risk factors. So we elected to do thrombolytic therapy. And this is another angiogram showing the occlusion, the external iliac artery. Thrombolytic catheter was inserted in the thrombus. This patient had thrombolytic therapy for 12 hours, following which the external iliac artery was patent, and she has regained the normal femoral pulse. And this is the image of the distal arterial tree, which showed no distal embolization. In conclusion, Mr. Chairman, intra-arterial catheter-directed thrombolytic therapy is an important tool which should be in the armamentarium of vascular surgeon, and it should be used in selected patients in whom surgery would be known to have better results. Thank you.
Thank you, Dr. Rashad, for this lively talk about the intra-arterial thrombolytic therapy. Can we have any questions from the?
Thank you. As you mentioned, the guidelines are telling that surgery is a +1 level of evidence speed, but still there is a room for catheter guided when the thrombus burden is heavy or in patients with poor mobility and so on. If there is other indication in which there is a favoring of catheter-based thrombolytic.
Apart from the medical indications, sometimes patient preference. In our culture, patients refuse surgery quite frequently, and we could offer thrombolytic therapy with an informed consent to the patient, keeping in mind potential complications.
Quick question. I just wanted to make a comment about when we should use thrombolytic therapy, because you need the luxury of time to infuse thrombolysis. So if you have a patient who has motor and sensory deficits, in other words, their neurologic exam is compromised, what do you do?
Yeah, I agree with this. If you have Rutherford class 2 acute ischemia, you need to relieve the ischemia pretty rapidly, otherwise you lose the leg. But as you very well know, in some instances, if you do surgery, the results are known to be so bad. So in this case, one has to compromise. But I agree with you, in some situations, you don't have the luxury of time.
Just two very fast comments. Number two is, if you don't see any runoff down in the leg, that doesn't mean that the vessels are not patent. Sometimes the flow is not very good. With contrast, and I go down to the node of the field to do the thrombectomy, it's usually successful, because the clot doesn't extend all the way down. Third is that I found that the coronary suction thrombectomy catheters are very helpful, especially for tibial vessels with residual thrombus.
Thank you for your comments. We use high quality duplics, so we are pretty sure when we find tibial artery thrombosis with high quality duplics, if you go surgical, you'll also find thrombosis. And really, the extensive distal thrombosis I'm talking about is not the one that you can extract with the poverty, but it's the one that goes into all the branches. And even you extract the main thrombus with the poverty from tibial arteries, you'll end up with a dead leg because of extensive thrombosis of the branches.
Thank you very much, Rashad. We have to end the session. We thank the speakers, we thank the audience, and we thank our co-chairman for this very instructive session. Thank you very much. We call upon the chairman of the next session to come to the podium.
Bismillah ar-Rahman ar-Rahim. We'll continue to the next session. The moderator is Professor Hisham Basuni, and I hope you enjoy it. And regarding the discussion, everyone, if he can go to YouTube and look for live event PVD, he will find the Congress already live. And you can put your comments, and we guarantee you will get the answer, because I think one of the most beneficial part is discussion. And because we are short of time, we can have open time discussion over the internet after the program. So, Professor Hisham.
All right, we're going to proceed with the second session, peripheral skills and peak of my practice. So the first speaker is Dr. Wael Shawab, different peripheral interventions.
Thank you for the pleasure to invite me to present this work. Intervention department depend a lot of things, like nice selection of patients. The personnel who work must be trained, even nurse, technicians. The instruments, the equipment, like machine. All staff working in radiation must be aware of the hazards of radiation, how to protect, wear glasses, wear aprons, a root shield, and do not know how to deal with it. Regarding the instruments, before we start to work intervention, I must know about all the instruments, kinds, catheters, guide wires, needles, stents, balloons, coils, all kinds. There's a lot of shapes of catheters, stents, types, self-expanding, closed cell, open cell, all types, graft stent, how to use it, with the flexibility of the stents. Guide wires. Have a lot of shapes of guide wire, all of kinds, before working in intervention. The shape of the catheter I can working in to select or selectively recognize a lot of small vessels in the abdomen and all bodies. Distal filter device, angiograph. Don't hesitate to use it in cerebral or even renal angioplasty. These are cerebral coils. Micro wires and micro catheters to navigate in small cerebral vessels to rise AVM. Even the glue onyx to fill the aneurysm and embolization of AVM. It's a machine. To optimize my work, I must select a very nice machine. We have a biplane angio machine. During work, I want shorter time of exposure to the patient and to me. Close the diaphragm, the amount of contrast must be calculated to prevent any complication in patients. So by playing save the time and contrast I can see in two directions at the same time. Technical aspects. Before working any procedures, I must explain to the nurse and technicians, all the people working with me, that the techniques, what we do, the all complication must be known to all people working in the caster room. And how to manage complications, like migration of the stent. I must have sneer to retrieve the stent if it migrates. Like this. Sometimes after deploying the stent, there is a fracture. What I will do, how I can manage this. The guide wire may be because of trauma and exposition of contrast may be used to the aneurysm. At the same time, same session, I deployed the craft stent. Must have in my room all these things. This is like a stent, it's right here. I can retrieve it with balloon, expand it with balloon and remove it or fix it in the area veins. Sneer to retrieve any foreign body or any in the vessels, it's easy to use it. There is a eye-wired trauma to the leak exposition of contrast. It's easy to treat with a coil. Just put a coil inside the vessels. Same thing in this renal angiogram after biopsy. A lot of cases with extravasation and arterial fistula is easy to treat with glue and coil. The difficulties and complications will start earlier, even with the puncture. So don't hesitate to use a fluoroscopy to puncture over the head of the femur to homeostasis, for good homeostasis after you finish your work. And for the fatty patient, exactly, I want all body to use fluoroscopy, even ultrasound guided. This is a finger technique and must be, it is not easy. Many complications occurs in section during the first step during work. Patient care and preparation, liver function test, coagulation profile, contrast allergy test, reassure the patient, explain all the procedures to the patient. There is some intervention procedures done in mild stroke, even it's ischemic or hemorrhagic. It is blood clots, prevent the blood to the brain. In the first 6 hours, do thrombectomy. But how to diagnose it? With CT and MRI, CT angiography, diffusion to diagnose infarction at early stage. The aneurysm rupture. There is a CT, don't hesitate to do non-enhanced CT to see the blood in subarachnoid space. The patient complains of, says that that's the worst headache ever. The protocol and strategy to manage the stroke the patient. First, do unenhanced CT. It's a fast. If it's infarction or hemorrhage subarachnoid space, then shift to CT angiography or MRI diffusion. Fast intervention is the rule. This is a subarachnoid space, the blood vessels in the subarachnoid space. This is a circle of Wells. This is the aneurysm, ruptured aneurysm, caused after 3 or 4 days severe vasospasm and secondary infarction. There is some nice cases of cerebral intervention. 40 years old female, right-handed, complaining with migraine. Incidentally, during MRI, we can see some dilatation in the middle cerebral artery. Right? Do angiogram, there is aneurysm, dilatation. CT 3D, there is aneurysm, wide neck. The strategy, we can change the strategy during work every time. we decide to use what's called Y stent. First deploy stent like this, then put coils, then put stents like this to keep the coils inside. Not this way. This is a diagram. This is a stent, then coiling through the stent. And this is the final result, complete occlusion of the aneurysm, and CT, also CT. Post-treatment, 2 days post-treatment, patient go home. Internal carotid aneurysm ruptured, CT done immediately, same days treatment. We did endovascular treatment, is a wide neck. So the coils may be retrieved out of distally. So I used balloon remodeling technique to keep the coils inside. This is the balloon is covering the neck, and this is the coils inside. This is a nice another case. Is a 18 years old female come with 5 months of pregnancy, progressive right side hemiparesis. MRI so mass-like in the deep temporal region. We decide to do CT cerebral angiogram. We found large aneurysm with thrombus. She is pregnant. This is the angiogram. This is a CT cerebral. This is aneurysm, and this is a thrombus. This is a huge thrombus. It was lucky. There is a professor, Lawrence Bell, visiting the Maadi at that time. We decide to terminate the pregnancy, or we'll treat the patient. We will use a flow diverter stent. It is a giant aneurysm. This is a video. How I can retrieve essential video. Roadmap. And this is the thrust of the stent to cover the neck of the huge and large aneurysm. It's not easy. It is a silk stent, handmade stent called the flow diverter to divert the flow from the aneurysm. I think this is a control just after deployment. There is some stagnation of flow inside the aneurysm. Then a few minutes after, complete cure. That's a control angiogram. She delivered full-term normal. Follow-up must be done at interval. Angiography, not angiography only, but we'll get an MRI to check the thrombus. It's shrink. This is the first preoperative post 6 months and 18 months. Bilateral ophthalmic aneurysm. The time. Thank you. Okay, sorry, the time is off.
All right, so we have 1 minute for questions. All right, we'll move on to the next presentation.
Result of plastic surgeon and multiple mind, and will give us information slightly well as an effective treatment for pediatric angina.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for allowing me to discuss with you this topic. Actually, I'm supposed to come and talk about some management of difficult cases of intervention way in treating vascular malformations. but with discussion with Professor Omar Farouk, he preferred, because I'm talking to cardiologists, to discuss with you one of your usual used drugs. My talk will be about propranolol as an efficient treatment, effective treatment for pediatric hemangioma. Hemangioma represents the most common benign tumor in infancy, affecting usually 1 or 2% of newborn. In histological studies early, they showed to be true tumors with proliferation of vascular endothelium. We have anatomical classification of propranolol. It could be superficial, appears like red nodular spots, or a deep hemangioma, which protrusion of overlying bluish state of telangiectasia, or could be compound. The natural history, and this is what usually the pediatrician told you, that I have a first sign. It is an area of ballot that appears several days after birth. And then it has a proliferative phase, then a quiescent phase, and at the last it has an involution phase which occurs over several years. When you diagnose pediatric hemangioma, it is very essential that to separate between infantile hemangioma, which we usually see because this is the common, and the other congenital hemangiomas, what we call the rapid involution congenital hemangioma, or the non-involuting congenital hemangioma. Also, it is very essential that you differentiate them between with the other vascular anomalies, as the high flow, which is fistulas and malformation, or the low flow, which is the capillary venous also combined. We depend, actually, at the start, you have to depend on the clinical image. The clinical presentation from the mother or the family is very essential. That, as I said, you started usually days after birth. And then you have to diagnose with ultrasound. If you are in doubt from the clinical, you use an ultrasound, which will differentiate for you hemangioma from the vascular malformation and the cysts. Usually, hemangioma is a true solid tissue. If you're in doubt and you can't say, as this nice girl, you can use the MRI, because MRI is a very specific feature which shows high flow anomaly with increased signal intensity in 2 weighted sequences with iso intense or decreased signal with T1 weighted sequences. MRI is very important and essential if to differentiate the solitary pediatric hemangioma or infantile hemangioma from other syndromes like the face syndrome, the face syndrome and the pelvic syndrome. So when we see pelvic syndrome, so when we see some cases like this, we need to do an MRI before we go to the treatment. So why we should treat? And this is usually what we hear. We know that the pediatric hemangioma is usually come, appear, and then disappear. This is not the case. If you follow many cases, you will find many cases of them that it may remain unresolved like this case. This case which we followed it for 3 years and it increasing, although at the start it is diagnosed as infantile hemangioma. Up to 30% of lesions result in texture changes and fibrofatty, and 5 to 13% of cutaneous hemangiomas ulcerate, which may lead to pain, bleeding, scarring, vision. And if it is in the exit, it could affect the respiration also. We need treatment because when you see cases like this, these cases, I saw them at this stage, 1 4 years, 1 3 5 and 4 years, which coming to you with disfigurement, and so you need treatment to prevent and improve disfigurement. The accepted treatments known for pediatric hemangioma, steroids, chemotherapy, cryosurgery, laser ablation, surgical excision, which is very doubtful in results. So all of us know that propranolol in pediatric hemangioma discovered in the literature in 2008 in a case with 9-week-old baby has growing segmental fissure hemangioma with ocular complication, 4-week course with steroids. The baby developed high output cardiac failure, so he had propranolol as a treatment for the cardiac failure. 7 days later, it improved significantly. 9 months aged, the function was restored, and the baby has very nice regression of the malformation. So at that time, from 2008 and 2009, it started appearance in the literature about using of propranolol in pediatric hemangioma. Mechanisms of action not known. Many theories might be the vasoconstrictive effect. Growth factors we don't know yet, which is still under research in any way. How do you use propranolol? We use the oral therapy, which is the majority of published study, 2 to 4 milligram per kilogram body weight per day. Some researchers used the topical. We tried the topical here in Egypt actually 2 years ago, but unfortunately we couldn't prepare it properly, so we stopped it. So we use the oral treatment. Adverse effect, as propranolol known for you, the hypoglycemia, bradycardia is the most common, but we need to notice that when we use propranolol for pediatric hemangioma, we don't use high doses as you cardiologists use it. We use less doses, so we don't have much side effects in our series. And a recent randomized controlled trial presented at the meeting of the American Academy of Dermatology, March 2013, conducted in 15 countries, included 456 infants, and it showed 60% clearance with only 3% clearance in the placebo, which was quite nice results. In March 2014, the FDA USA approved an oral preparation, which is the Hemanogel for pediatric formulation. So it approves its use in the treatment for pediatric hemangioma. What are my center cases? Our experience started in 2009. We have nearly 60 cases till now. We have we use usually baseline ECG for the cases and followed up by the cardiologist. We usually start at the lower dose, which is 2 milligram per kilogram per body weight divided by D, and then monthly adjustment by the pediatrician. This is my first case, which we saw it. We started in 2009. He's a 9 months age child with growing infantile proliferative hemangioma. We started him, which is 6 months later, he's seen, and at the age of 2 years, which is nearly 1 year and 3 months, and this is last follow-up at 6 years of age. I think you can see the difference between the two pictures. We actually advertised him when we found the marvelous results with propranolol in our cases. I advertised him in our Egyptian Journal of Vascular and Endovascular Surgery as a case. We have a vascular image, as an analyzed vascular image. And by the way, we thank you if you could, or if you like to share in our journal. It's established, and you will find it in the website. This is also another case, and before and after it, 1 year of use of propranolol, and with marvelous results. This is a very nice case, which I show you before and after it, and I think her mother sent me her this nice photo celebrating the success of propranolol with her young girl. This also an proliferating hemangioma in the leg, 3 months after treatment, 6 months after treatment, and nice months after treatment. I think you can see the difference. This is a very nice, interesting case. We thought it is rapidly involuted congenital hemangioma with a 3 months age girl, and you can see how far the extent of the hemangioma in the MR, and you can imagine that this only after 1 year or nearly 1 year and a quarter months disappearance, and a very nice picture of her face. So my take-home message is propranolol is likely to revolutionize the management of hemangioma and may offer the best medical treatment to date for the purpose, irrespective of age, location, extent, and phase of growth. Treatment might also be helpful in downgrading the size and local complication of infantile hemangioma, making the lesion more amenable to surgical excision later on. Due to the lack of long-term side effects and its high response rate, propranolol therapy has proved to be superior to existing therapies. Thank you very much.
far a very impressive presentation. What is your advice for us who are giving the dose of program load?
For what
The
again? Dosing. The recommended dose in the old literature, once it started in 2009 till now, is between 2 to 4 milligram per kilogram body weight per day. We divide it in 2 doses. So we start usually by 2 milligram per kilogram, and then once we got response in one first week, we start to increase it gradually according to the needs. We have a problem with propranolol in Egypt is that we don't have the oral solution. The easy thing is that we got it's enteral, it's cheap. We teach, we counsel the families. We let them they know how to do it. You know, you take the tablets and you dissolve it in a specific syringe, and then you use whatever the dose you need to do it gradually. So you prepare it every now and then. I got the, we might have in a way now we're starting to research with one you know him, Professor Saleh Shakir Musa from USA is very interested now in this topic, and he's helping us now to have our own preparation in Egypt through one of the international companies, so we make it easy. But till now we use الطريقه البلدي يعني ملهاش حل مش لاقيين لان because a solution if you get it from UK say is very expensive for Egypt.
I'd like to ask about the success rate of this line of treatment in the growing fertile.
I have literature-wise, it's more between 60 and 70% success rate. In our series till now, we have nearly, and I'm sure what I'm saying, more than 90% success rate. Because actually, I think the thing is you need first to know to diagnose it properly. You don't mix it with other. You know what happening now? You have many centers when you see cases. Once he got a swelling in an infant, he gave him propranolol, and then he said it is not responding. But actually, you need first to diagnose him, and then once you got the diagnosis, you will. I'm sure that you will. It is very successful. The thing is, we tried in the start that we stopped the treatment after say 3 or 6 months. You return to the family, you find the family complaining that the swelling is increasing in size again. So now we established the treatment for at least the age of 3 years.
All right, I think we're going to move on. Next question is asked. Very good question.
Okay. Yes, if it is infantile, yes, it is applied. Because you're given a systemic drug.
All right. Who is going to talk about very
Dear Chairman, Mr. Chairman, dear colleagues, thank you very much for having me here today, and thanks to my friend Dr. Muhammad Omar Farouk and the organizing committee to give me the chance to share with you this, I hope, interesting case. This case was presented just last month in the London PCR valve and shared by, in a session shared by Augusto Pichara and Martin Girard, and in the session of best case selection presented to that Congress. This was all about a gentleman that he was 76 years old. He is a little bit obese with a weight of 65 and a height of 175. And his risk factors are hypertensive, diabetic, smoker. He has presented with chest pain, class 2 angina, and syncope 2 weeks before the index presentation. Also, he had dyspnea, NIHA class 3, and his list of comorbidities including COPD with pulmonary hypertension, chronic kidney disease with mild renal impairment. And if you sum up all these risk factors to a risk score, it will get you a logistic risk score of 14% and a Euroscore 2 of 4.5%. And this makes him in the category of a very high risk patient. On his echocardiogram, as you can see here, he has a severe calcific significant aortic stenosis with an area of the aortic valve of 0.78 and an aortic valve annulus of 25. The peak gradient was 140 and the mean gradient was 85. The pulmonary hypertension was presented in the form of an RV systolic pressure of 77 and a mean pressure of 40. So this is a very complex aortic stenosis patient with a very high gradient. During the workup of the patient to solve his problems, this is what we have found in his multi-slice CT. He has a very hostile dual neck angulation abdominal aortic aneurysm with double angulation barely ranging between the range of 180 and 165 angles. The aneurysm itself is circular and measuring between 10 to 8.5 centimeters. So a huge aneurysm with a hostile neck and very unfavorable anatomy. His coronary angiogram, fortunately enough, was normal. He had normal vessels with minor irregularities, but no actual coronary stenotic lesions. And as you can appreciate here, the heavily calcific aortic valve in the fluoroscopy of the during coronary angiography. So we have such a problem. The problem that this was a high-risk elderly patient, critical symptomatic aortic stenosis, remind you the history of syncope, and associated with a very complex abdominal aortic aneurysm with unfavorable neck anatomy. We thought that treating the aortic stenosis first may lead to increased systolic pressure. This was one of the arguments, and that's present in your mind when you are dealing with a patient like this. And even the increased strain and risk of opening the aortic valve might make the aneurysm vulnerable to more dilatation and rupture even. And if you search the literature, you will find no consensus whatsoever about treating these rare subset of patients. So our proposed heart team and discussions came up with a novel simultaneous single-stage transcatheter treatment of both pathologies with endovascular aneurysm repair, EVAR, and then done first and followed by TAVI. And this is actually the first case worldwide to be done with this technique. There are few cases with combined pathologies that have treated aortic stenosis first in a single session, and then they treat it with EVAR or surgery later on. But there is treating both pathologies and putting TAVI from within the EVAR in the same session has not been done before. For my colleagues, or I'm sorry for those who know this very well, much better than me, but this is the quick animation of the EVAR treatment. We start by delivering the main, and this is what actually we are planning to do, starting by delivering the main body of the endograft through one limb, and in our case was the left side, which was the ipsilateral limb, and then you deliver the contralateral limb of the endograft, as you can appreciate here, making an overlap of 1 to 1.5 stents as an overlap part, and then you finalize by delivering the ipsilateral limb of the device, as you can appreciate here. So this is actually what we plan to do. We started with this under local anesthesia, and then when we moved to the TAVI part, we shifted to general anesthesia. This is just cannulation of the left brachial to have an guidance and the injections from this side, and then the first Landerquist wire from the ipsilateral position, the second Landerquist wire from the contralateral side, and with 2 wires we aim to have a little bit straightening of the aneurysmatic part and the angulated neck. As you might appreciate here, a little bit of straightening, but not so much. And this is an angiogram to show how much the hostile and complex nature of the EVAR. We started by introducing the main body, as you see as you saw in the animation, and adjusting the grafted part of the prosthesis just below the renal artery. So as you can see here, if I might quicken this a little bit, it's up to just below the renal arteries, as marked by these small dots into the, as you can see here in the angio. And then delivering the ipsilateral part, the ipsilateral limb of the endograft, making the same overlap, one stent overlap between both segments, and then ending by releasing the main body and delivering the ipsilateral part of the prosthesis. And then finally, we inflate the coda balloon just at the vessel seat points and at the stent overlap sites. We just having more dilatations to make sure of the sealing position of the sealing property of the device and avoiding later endo leaks. And this is the final shot, as you might expect from the device. We avoided over dilatation at the neck just to use this fixation neck angulation as a fixation mechanism to avoid migration of the device. After finishing this and over the same Lander-Quist wire, we started the TAVI procedure at the same, and then we shifted to general anesthesia. So we performed this part on local anesthesia, and then we shifted to general anesthesia, and this is again a quick animation for the TAVI part. I'll not waste your time. Just what I would like to show you is this part where in the TAVI procedure, this is for the balloon dilatation, and after balloon dilatation, we put the TAVI sheath, and this is actually the scaring part of the procedure. This is a freshly implanted EVAP endoprothesis that you need to pass this sheath, as you might see here, the blue sheath. This is a 19 French sheath, and we put it. This is only a theoretical risk because you have an ample amount that can let you go with it. And this is actually what happened. We just put the sheath as you are going to see in a moment. This is just the animation to show you how we inflate the valve in the native valve and have the new aortic valve working in position. And going back to the real procedure, this is the actual part. Here you can see how we introduce the TAVI sheath from within the EVAR endoprothesis up to its position. And I'm saying that this is theoretical risk because once you did this, you have the upper border of the TAVI sheath at the upper end of the prosthesis, and then you work usually. So actually, there is no risk that you can get into once you pass this step. Then the rest of the procedure is a routine TAVI. This is to show you how the valve is passing from within the sheath, from within the EVAR into the ascending aorta. The ascending aorta was, as you might have seen from the CT, has a little bit also of a tortuosity that we have passed with a little bit of difficulty, not so much, but a little bit of difficulty backward into the ascending aorta. As you can see here, the valve with the pusher into the ascending aorta, and the rest is routine TAVI procedure. We just introduced it into the left ventricle, positioning and checking the position under rapid ventricular pacing. And this is the moment of inflation. Under rapid pacing, you inflate, and also under a TE guidance, you can see and to manage and monitor all the possible complications that you might have from such a heavily calcified aortic valve. We have to take very much caution during removing of the balloon catheter of the TAVI, not just to impinge or to hang over the protruding stent of the EVAR endoprothesis. And then this is the final aortic angiogram, a very well seated position, new aortic valve with a very minimal aortic regurgitation. We have did a controlled CT angio after 1 week pre-discharge to the patient, which showed a well-seated new aortic valve. As you can see, aortic endograft was in position, sparing both renal arteries, as you might appreciate from the CT, and there was no endo leaks. Also, the TEE, the transthoracic echo, showed a mild aortic regurg, trivial mitral regurg, and a peak gradient over the aortic valve of 18 millimeters mercury. Again, we followed the patient for 1 year to make sure that he is doing fine, and we repeated the CT at 1 year and showed the same things. He is doing fine. He is asymptomatic with excellent LV function. The aortic regurg became trivial. The same well-seated new aortic valve in position, the aortic endograft with no endo leaks, and there is only mild increase in the size of left internal iliac artery aneurysm, as you might appreciate here from the CT angio. So, ladies and gentlemen, my take-home message is that severe aortic stenosis and abdominal aortic aneurysm can be both treated safely with endovascular approach in the same setting, and we think that an EVAR first approach seems a feasible and more logical option. Thank you so much for your interest.
I want to tell you that I had a similar case. She was a very old lady, like your case, with having both conditions, and she had a son living in the States, so she went to do it there in the States. We were debating for a very long time about which one to be done first, and it ended by the fact that the lady died while waiting for the choice of doing the aortic intervention first or the EVAR. So I want to congratulate you for such procedure, which is very difficult, and for taking the strategic decision of doing both of them at the same time.
Thank you so much.
One more question. Very short question. I'm very curious about this is a very excellent piece.
Thank you so much.
I'm wondering, very curious about the timing of the procedure.
Yes.
How much time will it take?
Yes. From skin to skin, we have taken exactly 2 hours and 25 minutes. We did it totally percutaneous. The closure at the end with a bare close device. So prepared from the start. So and because you spare the same steps from both procedures, you have the bare close for both. So use one bare close, one way over the same wire. So the timing was not very much. It's many steps that you can do, but if you will prepare the mind and all the team, and this is a work of a team. This is not a one-man work. This is a team, complete team with a cardiac surgeon, a vascular surgeon, and anesthesiologist. All the team are very well aware, very well planned discussions. All the steps are prepared, so not to waste so much time inside the cath lab. Thank you.
Thank you for the very interesting case. I just want to ask about the graft. Was it a regular stent graft or customized graft?
No, it's a regular. It's the Dennis, the Cox Dennis Flex endograft.
And you think if we ask for customized graft, it is very complicated.
Actually, you need a customized graft when you have some branches that you need to have fenestrations for. But in this case, fortunately, we don't have major branches that we need some fenestrations. So that's why we didn't need to go for a customized graft.
Thank you.
Thank you, Ahmed, for this very nice case. This is a very unique case done like that. My question: why did you think of doing both transfemoral? Did you think of doing the correction of the abdominal aortic aneurysm transfemoral, and the other you can go transport or transfemoral or something like that? Because I think there is you are very courageous to pass the aortic valve through this stent.
Actually, it takes a good preparation and not courage, because the endograft, internal lumen of the endograft at least is 13 millimeters. And the tabby sheath is not more than 7 millimeters. So actually, you are passing 2 tubes inside each other. One is 7 to 8 or 8 millimeters, and one is 13 millimeters. So actually, the risk here is just theoretical because nobody had done it before. But if you just try it before, and actually, I got an endograft. Non-sterile endograft, and outside the patient beforehand, I tried to pass the sheath inside, and there is absolutely no frictions, no resistance, nothing happens. So actually, when you just think of it, and it does take a good preparation, but it can be done. And as you can see, this is just needs to prove that it can be done. And then I think why we didn't do 2 procedures, because it can be done in a single procedure. If I'm the patient, I would like to have both pathologists treated in the same cath lab at the same time and get out of the cath lab with all my problems solved. I don't need to have surgery if I can. And surgery in this risk patient is still risky. The transapical approach is still risky. This is number 3. And number 4, it's transaortic is still again the surgery, and the transapical, as you need from the partner trials, is it does not have a very superior results over the traditional aortic valve replacement. And may I remind you, with the very high risk profile of the patient, the logistic Euro score is 14 and the Euro score 2 is 4 something. So actually, this is a very high risk patient for surgery.
But you said that the size of the limbs are actually advantageous for the PVD or PVD or the head. So it gives you actually a big space. And it straightens out everything. So you can go out very nice.
You know what, I'm afraid not only the introduction of the daily valve, but also withdrawal of the delivery system. It becomes part of during, after deployment of the valve, the valve becomes part of it, and withdrawal may before some.
Yes, we share the same fear, but
Because if you intend to do the daddy first, for example, let's say if you intend to do the daddy first, do the abdominal opening, there is risk of dehumanization and
rupture, absolutely.
So actually, it seems that the drawback to do throughout that in the same setting seems to be very complex, but still safe.
It's a very nice and unique case.
The balloon, Nabil, if I might tell you, the balloon, when you take it out, you take it inside the sheath. The upper border of the sheath is passing the EVAR procedure because it's a very long sheath. So actually, you don't expose the balloon to the EVAR prosthesis. And as Professor Basuni said, you have a very good amount of space there that you can manipulate these things without encroaching on H1.
Thank you very much.
Thank you. Only one, this case reminds me by the English phrase that if you don't have a way, pave one. So this is what we have done. We just paved the way for the EVAR. Thank you so much.
All right, can we move to the next presentation by plasty as bailout in chronic ischemia cases. Conduct and result of the surgeon's testimony.
Bismillahirrahmanirrahim. Thank you, Mr. Chairman, dear professors and colleagues. It's an honor to present in front of you this prestigious gathering. My talk today will be about percutaneous profundoplasty as a bailout procedure in the treatment of critical limb ischemia. I'll start my presentation by this question: does deep femoral artery revascularization as an isolated procedure play a role in chronic critical limb ischemia? And the answer is yes in selected cases. Why is that? Because profound femoral artery provides collateral blood flow to the lower limbs in long occlusions of the superficial femoral artery. And the profound artery is essential for maintaining limb viability in occlusive SFA arterial disease. So concomitant lesions of the profound femoral artery causes critical limb ischemia. The options to improve blood flow to the limb in cases of occlusion of the SFA are bypass grafts, profundoplasty, either surgical or endovascular, or in the last cases, sympathectomy. And since the advent of endovascular treatment of the profound arteries since 1978, many cases were done and the procedure proved to be feasible, safe, and remains controversial as a therapeutic option for critical limb ischemia. By reviewing the literature, few publications were studying the results of the percutaneous profundoplasty, lacking the long-term follow-up results. And in one study that had been published in the Journal of Endovascular Therapy, 2001, they studied 32 limbs in 31 patients that were followed for 34 months, and they found that the clinical success rate of percutaneous profundoplasty was 91%. Hemodynamic success defined as ABI more than 0.1 improvement, 97%, with limb salvage rate in hospital 94%, and after 34 months 88%, and symptomatic improvement in the symptoms of the patient 88%. In another study that has been including 21 limbs, 14 PTA and 7 surgical limbs in 20 patients that were followed for 12 months and published in the Journal of Endovascular Therapy 2004, the results were technical success in 100%, limb salvage rate in hospital 100%, and the most striking results were the improved wrist pain in 67%, but failed in ulcer healing in only 11%. The target lesion revascularization at 12 months were 49%, and major amputation rate was 36%. In another study, they included 15 patients with critical limb ischemia that followed for 29 months, and also the technical success was the same, 100%, limb salvage rate 93%, and at 3-year follow-up, the primary patency rate was 80%, and the secondary patency rate was 87%. In a study by Bolia and his group in Leicester, UK, they compared the isolated procedure of profundoplasty to combined profundoplasty and SFA and followed up these lesions for 12 months, and the results were technical success comparable of the isolated procedure to the combined procedure, as well as the 12 months amputation-free survival and the target lesion revascularization were comparable. So what are the indications for isolated profundoplasty? It includes long SFA CTO from the origin, total occlusion of the SFA from the origin, associated with insufficient autologous vein, poor distal runoff, recurrent bypass occlusions, and the patient's refusal of bypass surgery, as well as high surgical risk due to comorbidities. What are the predictors for good results? It includes good distal runoff for profound collateral flow, non-diabetics, and Fontaine classification 3 better than 4, which means wrist pain improves better than ulcer healing. And we are herein we're presenting our case, a male patient, 63-year smoker, diabetic, complaining of severe wrist pain with an ABI of 0.5. This patient has a very distinguished past history, including SFA multiple stents, as we can see here, multiple stents, and common femoral artery stent across the profunda femoris artery, occluding the orifice of the profunda, and the iliopopliteal bypass supragenicular using synthetic graft that has been occluded. Here is the multiple stents in the SFA and across the orifice, and this is the synthetic graft from the iliac artery to the popliteal supragenicular that has been occluded as well. So this patient has multiple procedures that has been deemed occluded and failure. The procedure, the standard crossover approach, local infiltration anesthesia, diagnostic angiogram was done, and dilating the external iliac artery stenosis. As we can see here, here is the external iliac artery stenosis, a crossover procedure, and angioplasty of the external iliac artery. As you can see here, the common femoral artery is totally occluded across the orifice of the profunda, and this is the SFA with the multiple stents that has been occluded. Trial of opening up the SFA through its lumen, not the subintimal plane, deemed failure. We couldn't pass through this occluded stents. And then we decided to try to open the orifice of the profunda femoris by using a stiff Telomo wire, 0.35, and we succeeded to cross the orifice through the stent of the common femoral artery. And here is the wire inside the common femoral, this is diagnostic angiogram. As you can see here, the dies through the profunda femoris with a very scarce flow through the distal runoff in the popliteal artery. And this is before dilatation and stenting. Here is the distal runoff through the posterior tibial artery. Then, after angioplasty, the flow was not adequate. Then we decided to put a stent, self-expandable stent from the profunda across the stent in the common femoral to the common femoral artery, and then post-dilatation by balloon angioplasty. Here is the deployment of the stent. As you can see here, the stent is opened from distal into the common femoral artery. And this is the final angiogram, completion angiogram, showing good blood flow from the common femoral through the profunda, through this robust collateral that filled out the distal runoff into the popliteal and the posterior tibial artery to the ankle. So this is the preoperative picture with occluded common femoral artery, and this is the postoperative with open common femoral and orifice of the profunda femoris. 1 year later, the patient was evaluated for contralateral stenosis of the SFA stent and showed this natural bypass from the profunda that filled out the distal popliteal artery. And the patient wrist pain disappeared with improvement of the ankle brachial index from 0.5 to 0.7. So in conclusion, percutaneous profundoplasty is safe and effective procedure and could be considered as an alternative procedure in some patients with critical limb ischemia where you cannot do a bypass surgery, whereas isolated profunda revascularization might be a safe and efficient treatment in critical limb ischemia with rest pain. It doesn't suffice to achieve wound healing in critical limb ischemia. Thank you.
Thank you very much. I have comments. First of all, fundoplasty success, whether you do it endovascular or open, depends on the collateral flow
to the foot,
segment of the popliteal artery.
Right.
So if you have a occluded popliteal artery, the results of fundoplasty are not very good.
This is one of the predictors of success of the procedure.
Yeah,
Right.
so you really have to have a good popliteal segment which is in collateral, as well as a good profunda femoris artery. And many times in diabetics, for example, you see a very small
Profunda with multiple
stenosis. Even though you can angioplasty that or stent it, doesn't really give you a dynamic.
Right, absolutely right. Right.
My question is, what kind of a stent did you use to overcome the existing stent? And I'm somewhat disappointed that I see this in Egypt quite a bit, that people are stenting across the common femoral artery,
yes,
which is really unethical.
Right.
It should not be done because you basically cage
it's a malpractice.
the profunda and close it. And
right.
That's unacceptable.
We use the self-expandable stent 5 millimeter Protégé EV3 Evercross. And after deployment of the stent didn't open well, so we had to do post-stenting dilatation.
So why did you consider a balloon expandable stent instead of stent?
It would be a better idea, but we couldn't have it on shelf. Thank you.
Thank you very much. Any other questions? I can't hear you. Can you come closer?
If anyone has a question, my name is Steve.
And he's saying that we would prefer a self-expanding stent because it's more flexible across the joint. And I agree. Is that correct? Yeah.
I have the pleasure to introduce our last speaker, all that we have arrived. We're going to talk about carotid artery stenting using double voltage.
Good morning. First of all, I would like to thank the Congress Committee for giving me the chance to be here with you today and to present this case. And for sure, thank you, Dr. Omar Farouk, very much. My presentation today is a case presentation about carotid artery angioplasty using double protection devices. As an introduction, in 1979, Matthew Sital performed a balloon dilatation of a stenosis of the carotid artery. 10 years later, a stent was implanted into the carotid artery for the first time to improve the results of balloon angioplasty. In 1996, Ferron and colleagues first described the concept of cerebral protection using during the carotid angioplasty and stent placement. I think we have to keep in mind that carotid artery stenting has evolved to treat carotid artery disease with the intention of preventing stroke, as stated by Godi et al. Now, regarding the case, our patient was 70 years old male pediatrician presented with transient ischemic attack in the form of a short attacking fainting with no history of previous transient ischemic attacks or cerebrovascular attacks. He was not diabetic, hypertensive, but he was controlled on medication with a past history of CABG 12 years ago. During the lab checkup of the patient, we encountered that the serum creat was 2, and the patient has recent coronary angiography showed patent bypass. A high-quality duplex was performed, revealing that 90% right internal carotid artery stenosis caused by an atheroma encroached on the orifice of the external carotid artery, causing severe stenosis. And regarding the characteristics of the plaque, it was mostly equiescent. MRI brain done showing multiple small infarcts. Unfortunately, we couldn't do CTA and avoided because of the elevated serum creat, and instead we did MRA. These are the images of the duplex. Here we can see, sorry. Here you can see the common carotid artery, the external carotid artery, and the internal carotid artery with the turbulence here. In this image, we can see the peak systolic velocity of the common carotid artery and the diameter of the common carotid artery about 78 millimeters. This is of the external carotid artery, and distal to the stenosis, we can see that the peak systolic velocity is about 39 with damped flow. In the lesion, the right internal carotid artery velocity, peak systolic velocity is reaching 3 meters, denoting significant, very significant stenosis, and the diameter was about half centimeter. These are the images of the MRA showing patent left side and nasty, very tight stenosis of the right internal carotid artery. And these are the this is the image of the circular coils with collateralization. Now we discussed the different modalities of treatment with the patient. As I said, he is a doctor, and we encountered the elevated serum creat level in his case, and the modalities of carotid endarterectomy and angioplasty. And the patient searched online, and finally he decided to do carotid angioplasty and refused to do carotid endarterectomy. So we prepared the patient with good hydration and anastasis and gave him dual antiplatelets and statins prior to the procedure, and started our procedure with the right common femoral arterial access with 6 French sheath and a Bernstein catheter over the wire. We didn't do an angiogram for the arch to reduce the amount of the dye, and here this is the first image in trial to identify the origin of the anomaly. Then here to identify the subclavian internal carotid. This is the select of the subclavian. And this is the selective catheterization of the internal, the common carotid artery. Multiple projections are taken to choose the best view to treat this lesion. Sorry for the delay of the image. It's not working. Yes. Then we changed the wire to the stiff wire, which is a Roadrunner, and inserted the MoMA device. As the external carotid artery was nearly occluded, we positioned the MoMA device proximal to the lesion, about 2 centimeters, completely in the carotid, in the common carotid, internal carotid. Then, sorry, I don't know what happens with the pictures. We inflated the proximal balloon of the MOMA device, then inserted through the working channel of the MOMA device filter, which was filter wire of Boston. And then we pre-dilated the lesion with a small balloon and inserted the stent. After insertion of the stent, balloon dilatation of the stent, with the residual stenosis, as you can see, about 20% left intentionally. Here you can see the residual stenosis. Then withdrawal of the deflation of the balloon, of the proximal balloon, and sorry, and the travel of the filter. It runs very slowly. I'm very sorry. Okay. This is the MRI brain of the patient before and after with no significant strokes. And we did serum creat for the patient. Actually, it improved after 3 days to 1.8. Regarding the review of literature, there was a lot of work, and I just want to focus about certain points. The first one is protection devices important. It's a matter of safety. This is a meta-analysis done by Gard et al. In 2009, including 24 studies. For sure, the first study, 1996, describing the protection device up to 2007, and it showed that the results improved with the use of protection device would decrease the risk of strokes with the protection device use. The second thing is the protection device give us safety, 100% safety? The answer is no. I just give an example from a recent publication, 2014, by a paper done by Frendiez in Spain. Here you can see that with every distal protection device or proximal protection device, always there is an incidence of stroke. It is not preventable. It's not 100% safety. The same concept was stated by Ricotta et al. In 2011, when he stated that no device can completely eliminate the risk of embolization during CAS. No embolic protection is completely effective. My conclusion, that there is no single protection device gives 100% protection, and every effort should be done to increase the safety of the procedure. And so we introduced this technique with double protection device, although we know that there is a problem still with the cost, hoping that in the future new devices will evolve and may reduce the cost. Thank you.
You used to set double protection, meaning you had a filter up there.
Yes, sir. It was a filter wire EZ of Boston.
You just used that wire because you had a wire that had a filter, so they used the tension.
No, it was intentionally in the beginning of the procedure.
If you have a MOMA device that causes reverse flow, so
yes, sir.
you have to use the double protection.
The idea was in the planning of this case that MOMA device, although it is a great device, it won't ensure 100% protection. Adding as a trial to add a filter also may decrease the risk of stroke. So it is just an idea, and we tried it.
maybe this work to be, you are suggesting new way of handling things, maybe to document, for example, the number of bits you bring to transfer order with this and without this combined. This might be more convincing or more expenditure.
For sure. So maybe this is just one case, the first case. Maybe we need a study to study this technique and the cost effectiveness of this technique. But this is just the start.
Really, it's an interesting case.
Thank you.
First of all, I have to make a statement. When you are complicating the procedure, you are increasing the risk of complications and troubles. This is number one. And second, you have to have certain criteria for using the double protection technique. So these criteria includes very unstable plaque of the internal carotid. This is very important. I can see that in this case it is not a complicated plaque. It looks to me a straightforward case. So you can use one of the protective devices, either the proximal or the distal protection, and then you can use a closed cell design in order to avoid any plaque protrusion into the tube. This is my idea. Finally, this is a very good case.
Can I answer, please? Regarding the vulnerability of the plaque, there are many criteria. We perform a very high quality duplex prior to the procedure, and as I said, the plaque was mostly equilucent, so it is to some degree not only the percent of the stenosis, it's the lipid content, and this plaque by duplex was very equilucent, so we considered it as a vulnerable plaque. And we need a good protection device. Another thing that the filter, the idea itself, as I said, the MoMA device in all studies, all through the world, it doesn't give 100% protection. So the idea is about to use another technique. I know it's complicating the procedure, yet it is calculated. What I mean that we inflated the proximal balloon of the MoMA device, so decreasing the flow, then introduced the filter, so decreased the incidence of showering during introducing the filter through the lesion and the manipulation.
We don't judge risk of embolization by gram. It's by plaque analysis. So this was the proof of that. It was also recently I think TIA in a 70-year-old patient, so they're all accidents. The other thing, something special on this case, it did not have an external carotid. Actually, it was 100% still, it was not approved. So the MoMA device did not achieve complete protection because it did not place the external carotid. So this is the justification of the doctor.
Have the patient accepted that arthritis still? What would you do?
Yeah, he was a physician. In fact, he's a senior physician, and he had full access to all medical advice, not only in Egypt, but also in other countries. So he made his decision fully aware of it.
That's the case with arthritis.
My final comment is just Dr. Rashad. I have to put some criteria for very high-risk cases in order to do this double technique protective device. That's all.
Thank you very much. We'll go to the next session.
Bismillahirrahmanirrahim. The next session, the moderator will be Professor Rashad Bishara, the moderator, and I promise you a very interesting lecture from two eminent professors. Professor Muhammad Hosni, who's probably the most experienced person to do IVAR in Egypt, and Professor Hamdi Suleiman. Professor Rashad.
My pleasure to start this session. It's about references. It's about how to manage refugees. I have the pleasure to introduce Professor Muhammad Hosni, and he will deliver his experience showing the challenges of individual cases.
Mr. Chairman, dear colleagues, it's my pleasure to be here. I've been asked by Dr. Omar Farouk to present difficulties that might we face during doing EVA. First of all, I would like to tell you that EVA is not a one-man show, it's a teamwork, including a vascular surgeon, cardiologist, ICU, and definitely if you're doing a dissection of thoracic cases, you need an TEE, the anesthesiologists, and definitely the scrub nurse and the technicians are integral part of this team. Remember at first, the 6 P's rules, proper preoperative planning, prevent poor performance. And the planning should be done by the doctor, the main operator. It's not the responsibility of the company, it's your responsibility. And so don't rely on the measurements done by the company, please. All of us are aware of these different sizing and available from different companies to size the aorta and to choose the device that you are going to deploy. But at first you have to have a good CT with 3-dimension reconstruction. This CT should be dated within the last 3 months before the implantation date, and it include from the aortic arch down to the infrapopliteal arteries in order to detect any associated aneurysm, which might reach up to 15%, and to assess the femoral artery, the access site, and the thickness shouldn't exceed 1 millimeter. And you can use one of the different specialized workstations available, either the Osiris, the Terraricon, or whatever system you would like to use. These are the major regions, anatomic regions that you should care while doing the planning. The first is the aortic neck, the second is the aortic bifurcation, the third is the iliac arteries and the femoral axis. Concerning the neck, the diameter shouldn't exceed 18 to 32, as the available grafts in the market ranges between 21 and 36, and the length should be between 10 and 15 millimeter. If the infrarenal angle is less than 60 degrees, the acceptable length is 1 centimeter, and if it's between 60 and 75 degrees, the permissible length of the infrarenal neck should be at least 15 millimeter. The diameter of the iliac arteries should be between 8 and 22 millimeter, and this is also because the available grafts sizes ranges between 13 and 24 millimeter. The landing zone in the iliac artery should be at least 15 millimeter, and the axis for the femoral artery for the ipsilateral side, I mean for the introduction of the main body, should be at least 6.7 millimeter, and for the contralateral side should be at least 5 millimeters. This is how to know your angles and measure your angles. This is the line, different lines that you use, and this is the suprarenal angulation, and this is the infrarenal angle. Definitely you have to look at your CT quite well to show if there is accessory renal arteries, especially the lower polar artery that supplies the pelvis and the ureter, and the upper ureter, I mean, and you should be sure that there are no thrombus in the aortic neck near to this orifice of the renal artery in order not to dislodge any material within the renal artery. If you have a funnel shape or a reversed funnel shape aortic neck, if it is in the range between 20 to 30%, it's acceptable to do an EVAR. But if the range is more than 30%, it's not permissible to do an ordinary EVAR. Because if you take the diameter of the small neck as the reference diameter for the proximal sealing zone, then an endoleak will occur. And if you choose the larger neck diameter, then an enfolding will occur. The second point is the aortic bifurcation. The diameter should be at least 18 millimeter in order to be able to do an aortic bi-iliac graft. If it's smaller than that, you can do an aortic uniiliac with occlusion of the common iliac artery and femoral bypass, or you can do an aortic bi-iliac, and at the site of the aortic bifurcation, here you can put two balloon-mounted iliac stents at least 10 millimeter each. Which side you should choose for insertion of the main body? The companies keep telling us that you should choose the less tortuous and less calcific side to introduce your main body. But if the contralateral side is the more tortuous side, this will make cannulation of the gate of the contralateral limb a little bit difficult task. And so in majority of our cases, we recommend using or introducing the main body through the more tortuous side. And with these devices available now, they are small French size, hydrophilic, and the stiff wire usually straighten this tortuosity. There will be no difficulties at all. To do it percutaneously or to do it by an open technique, in percutaneous technique, we can use either a ProGlide, two devices for each arteriotomy in a crosshair configuration, or to use a ProStar, a single device for each arteriotomy. There's a study on the independent access site closure study that compares both techniques concerning different points, and it found only significant difference between both techniques in favor of PVAR concerning the procedure time and time to hemostasis for the ipsilateral axis. But concerning the anesthesia, time for anesthesia, the estimated blood loss, and the blood transfusion, there is no statistically different values. This study showed that the closure device was successful using the ProGlide in more than 96% of the cases. And the results showed safety and effectiveness of the pre-closed ProGlide, including femoral artery access site of up to 21 French sheaths. And there is no hospital mortality, 30-day early hospital mortality. In conclusion, this trial showed that among trained experienced operators with suitable patient selection in a randomized multi-center trial, PVAR, using the 21 French profile out delivery system is safe and can be used. But this study ignored the problem of distal embolization, which I think is higher with PVAR than in CVAR. And definitely, if you are doing a PVAR, you should examine the foot of the patient at the end of the procedure. Be sure that it's warm and there's pulsations. Otherwise, you have a very good EVAR with a patient have an amputated limb. It's very important to use the CT image to detect the best position and the best views for the renal arteries and the internal iliac arteries. And this can be done pre-operatively, and during operation, we usually put a paper like that, denoting the tube position during shooting the renal arteries and showing both internal iliac arteries. If by mistake the renal artery has been covered, this a very serious situation, and this has been written in a book, but I don't prefer to use it. By pulling down the device with partially inflated aortic balloon under fluoroscopy in a caudal direction and put through a brachial axis a covered stents in the renal arteries. But I prefer in these cases to do an open conversion and do an iliorenal bypass. Sometimes, especially with severe angulation of the neck, during retrieval of the sheath after full deployment of the main body, there will be entrapment of top cap device in the proximal struts. And this can be solved either by straightening the unfolding of the neck by using an extra stiff wire through the contralateral limb, or even passing the contralateral limb without opening it, just to straighten in the neck and be able to capture the top cap. Sometimes there is severe difficulties in cannulating the contralateral limb, and this is usually due to either improper contralateral limb orientation or the main body is twisted, or the contralateral limb doesn't fully open. And so during the deployment of the main body, you should be very cautious, and the line of the radio-opaque stain markers along the length of the main body should be avoided to be twisted as the sheath is retracted, and you can slightly rotate and the main body as a unit, not the sheath kept in place and rotating the endograft inside it separately. You can use this technique, which is known as the up and over technique, by cannulating the contralateral limb from the opposite side, from the ipsilateral side, I mean, passing a wire and then snare it from the contralateral side and proceed as usual. Or you can go through a brachial axis with a floppy wire and cannulate the contralateral limb, snare this guide wire, and establish a through and through axis, and then continue to deploy the contralateral limb. If the device has been deployed in a lower position, this usually happens with quick deployment, and this, if can be recognized early, some available grafts now can be recaptured and reoriented the gate and reposition everything and reopen the main body again. But if the graft you are using, you cannot do that with it, then you have to reposition the introducer sheath in a higher position, in a higher location, and by pushing the device a little bit more in order to allow the contralateral gate to flare open. If you recognize this problem late after full deployment of the main body, then you have to attempt several methods, either by up and over access with curved catheters and snares in order to open it, or convert the procedure into autoimmediate. The problem in internal iliac artery, either it's aneurysmal or arising very close to the aneurysm, and if it's aneurysm internal iliac artery, only it's a rare situation, represent only 0.3 to 0.4 of all intra-abdominal aneurysms, and the best position to see the opening of the internal iliac artery is to go into a 20 to 30 degree oblique view in the opposite direction, taking into consideration that occlusion of the internal iliac artery in one side results in hip and buttock claudication in about 25 to 40% of your patients. And so if the internal iliac artery is aneurysmal or is coming out from the aneurysm, you can coil it through an ipsilateral or contralateral approach, but taking into consideration that this patient may suffer from hip and buttock claudication, or to do a branched iliac, use the branched iliac stent grafts. It's an easy one. You can introduce it from the side you are going to deploy it, opening till the internal iliac opening becomes patent, cannulate it from the contralateral side, put a covered stent, and then fully deploy the stent you need, and you can proceed if the patient has an abdominal aortic aneurysm after that. This is the picture. Cannulation, and after full deployment of the unilateral iliac branch. Most of our patients are fragile, have a borderline kidney functions, and we want to minimize the amount of the dye you are using. In most of our cases, we don't use more than 60 to 100 cc's of dye, usually 15 to 20 shots at the beginning to localize the renal arteries, and 15 to 20 cc's after deploying the first two stents for accurate positioning, and then 15 to 20 cc's of dye to locate the contralateral internal iliac artery, and the last one for control angiography for accurate positioning and detect any complications like endoleak. We follow our patients only by duplex scanning at 1, 3, and 6 months, and then yearly interval. If there is endoleak, then we'll do CT angiography. Post-operatively, the patient will be treated only with antibiotic, non-steroidal, anti-inflammatory, because most of these patients have low-grade fever from absorption of the blood in the aneurysm after deployment of the covered stent, and antiplatelets, aspirin. These are additional tools that might help you much in obtaining good results and minimizing the amount of the dye you are using. First of all, the CT Fusion scan, it's a software that can be added to the general electric machine. It's very useful in fenestrated grafts, but can be used also in ordinary EVAR to localize the renal arteries. Usually, the CT Fusion scan put dots or circles at the site of the orifices of the main branches that are coming out from the aorta, and this will facilitate cannulation of these vessels. And the second tool, which is very beneficial, is the IVUS-1, especially definitely in dissection, but even in abdominal aortic aneurysm, it helps you in having exact measurement of the aortic diameter. At the end of the procedure, you are sure that there is no endoleak. Remember that it's a teamwork, it's not a one-man show, and thank you.
Thank you very much, Dr. Muhammad, for your elegant piece, and we allow for short questions. Welcome.
Thank you, Professor Muhammad, for this very interesting talk. I'd like to ask about if there is Egyptian registry for EVAR, Egyptian registry for EVAR cases of EVAR, and what is the incidence of injuries in devices?
I don't think that we have any registry. We can start doing this, but we don't have registry for EVAR.
Very nice presentation. I have a question regarding the iliac branch device. It's my understanding that the iliac branch device is used for common iliac artery aneurysms. Is that right? It's my impression that the iliac branch device is used for common iliac artery aneurysms. You have to have a very good landing zone in the hypogastric. So if I do see the large hypogastric aneurysm, it's very difficult to get into the distal branch to the iliac artery once I prefer to embolize. Otherwise, can you comment on that?
Definitely, sometimes, especially if the internal iliac artery is coming out of the aneurysm, it's very difficult even to cannulate the internal iliac to embolize it. And sometimes you spend an hour or more to be able to cannulate it if it's coming from the aneurysm. But if you are going to coil the internal iliac artery, even in one side, the incidence of head and buttock claudication is 25 to 40%.
Yeah, I agree with you, but iliac bifurcation devices are designed for common iliac artery aneurysm so that you can extend into a normal hypogastric.
No, you can do it even if the artery is arising from a common iliac artery. I don't understand you quite well, but if it arises from an ordinary common iliac artery, but you don't have a landing zone, there is no need to coil the internal iliac artery because the graft will seal the opening from it. You are in need to coil the internal iliac artery only if it's coming from the aneurysm.
Well, we agree on that. That's not my point. My point is that your landing zone in the common iliac artery for an iliac branch device has to be in a normal arterial segment. So if you have a large hypogastric artery, you have to get into the very small distal branches.
Definitely. Okay. I agree.
I have a question, please. Regarding the indication for yourself, your practice, thank you first for your elegant lecture. And regarding the indication of the abdominal aneurysm, when you touch the patient, it is asymptomatic.
The indication for intervention in aneurysm, in abdominal aortic aneurysm, in the size 5.5 centimeters or more, or if it's less than 5.5 centimeters, but it's increasing by 6 millimeters per 6 months or 1 centimeter per year, or if there is associated complication with the aneurysm, even if it's smaller than 5.5 centimeters.
The second question, do you have any experience with young patients? Because in young patients, we know that the axis might be different and the relation with the aorta is more. Do you have any experience with that point?
We have few patients, especially arthritic patients and Behçet diseases. We have done some cases in Qasr al-Aini for young patients. And usually with the new devices, the French size is maximum 18 French size for the main body, and so you can do an EVAR even in young patients.
And regarding the other subtype of patients regarding the blunt trauma, the abdomen, is there any technical advice for this patient? Right?
For trauma of the abdominal aorta, there is no, I can't recall any studies about it. But for rupture abdominal aortic aneurysm, there are a lot of cases outside that have been done by percutaneous technique. But the problem here in Egypt that we don't have this material on shelf, and so it will be difficult to do it for rupture cases.
Professor Mohammed, thank you very much for this elegant presentation as usual. My simple question regarding aneurysms of the descending aorta, where do we stand? We know there are limitations, we know the coronary arteries, the angulation or passing the device to the aortic arch, and so forth. So what's the current status?
For the time being, there are a lot of studies putting small stents, covered stents in the ascending aorta, but it's not available commercially up till now. Thank you.
May I call upon Professor Hamid Ismail, who is going to talk about endovascular.
Thank you, Mr. Chairman, dear professors and colleagues. It's an honor to present a case. This is one of our starting experience in the project of endovascular intervention of the aorta, whether it's thoracic or abdominal aorta, in collaboration with our cardiothoracic surgeons. As Professor Mohammed Hosni stated that this is teamwork. Yes, definitely, it's a teamwork. We have a hard team in our National Heart Institute and started with these cases. 1 year ago, with cases of acute aortic dissection, chronic dissection, aneurysm, and we have 30 cases of thoracic endovascular intervention and 3 cases of abdominal endovascular intervention. The patients who with thoracic aortic pathologies, very often acute life-threatening conditions are challenging and sometimes difficult to treat. And the primary goal of the treatment of thoracic aortic pathologies is to prevent death, secondary to the pathology or related interventions. And surgical treatment with segmental aortic resection and guide insertion implemented by the Becky in the 1950s has been considered the standard treatment for many decades. We have some indications for endovascular treatment of thoracic aortic diseases. Thoracic aneurysms, whether degenerative, atherosclerotic, post-traumatic, and stenotic post-surgical. Acute and chronic dissections stand for type B, penetrating ulcers, intraneural hematomas, traumatic transection, connective tissue disorders. We are confronted with young male patients coming from Alexandria with unexplained hypertension and accidentally discovered of 6 months duration. The blood pressure was 160/100, associated with vague chest heaviness and compression sensation. The routine X-ray showed dilatation of the ascending and arch of the aorta. They did an echocardiography, showed mild left ventricular hypertrophy with good systolic function, dilated aortic root, it was 4.2 centimeter,
bicuspid aortic valve with no gradient across. Pressure gradient of 18 millimeter mercury across descending thoracic aorta, denoting 9 degree of aortic coarctation. The patient referred to me from a chest position after CT scan, and CT scan showed multiple thoracic aneurysm of variable sizes, starting from the origin of the left subclavian artery down to the descending thoracic aorta. This is the echocardiogram and pressure gradient across the coarctation segment, plus 18 millimeter mercury. It means mild narrowing of the descending thoracic aorta. And this is the picture. Here you can see dilated aortic roots, it's 4.2 centimeter, and multiple aneurysms starting here, a small one at the origin of the left subclavian, another big one follow gate, and a larger one later on. This is the distal one, and the 3 aneurysms. This is another picture here, the 3 aneurysms of the descending thoracic aorta. It was an ugly aneurysm, I didn't see it, and I tried it with our surgeons see cases highly, so we can discuss the etiology of these cases. We started the work upfield, and this is the multiplex CT scan of the patient, and we tried to see the diameter and dimensions of the neck. Diameter at the left-hand carotid was 28 millimeter. Diameter before the thoracic aortic aneurysm, it was 27 millimeter. This is the distal diameter of distal neck, 23.5, and this is the total length of the proposed graft to be starting from the origin of the left subclavian here down. It was 120 millimeter less, and the proximal neck will be 32, and the distal one will be 28. The left subclavian is planned to be cut. This case was discussed with the cardiothoracic surgeon, and he agreed to put a graft stent covering all these aneurysms and covering also the left subclavian artery. Here is the first diagram. We have a detail from the right radial artery and the multipurpose catheter passing through the aneurysm. You can see how large is the aneurysm here, the previous one, the second, the first, and first, second, and the third one. And you can notice here some constriction of the descending thoracic aorta. This is the ugly picture we have to cover. Another one, maybe more clear, with more another position of the pigtail to visualize the origin of the subclavian. You can see here the 3 aneurysms here. This is 1, 2, and 3. And this is the constriction of the descending thoracic aorta. So this is a device, and I found some difficulty while crossing the narrow segment of the coarctation segment here. That's why I go very slowly, and then there was some friction here from the device in this constriction of the coarctation. I didn't try to dilate it for the procedure, and later on we will dilate it. Here is the device, and we have to fix the device properly, and the landing zone is at the origin of the left subclavian in order not to miss the small aneurysm at the origin of the left subclavian. As you see, it is at this point exactly. Another picture again. And then after deployment of the device here, you can notice there is some injury here in the proximal segment, containing of the left subclavian, and there is a constriction here at the area of the palpation of the aorta. So we start to dilate with a compliant balloon, this segment in order to seal the leak, and down to dilate the narrow segment. Again, you can see how this segment was tied, is dilated with the compliant balloon. Finally, this is the final picture. We can see the artery. There is some leak, very small, and the aneurysm disappeared completely. The patient was worried, and I told him that I have to do a CT scan after 1 month, but he went to Alexandria and came back 2 weeks later with this CT scan after 2 weeks. You can see complete healing and covering of the aneurysm with nothing, and still there is some flow in the left subclavian artery. In this case, and in a lot of cases, high anatomical variations, you can find deployment challenges and risks. For example, verticality. Manipulations here, the coverage or coverage of critical branches may lead to risk of neurologic complications or mesenteric ischemia in the lower abdomen. Larger devices in smaller anatomy with females, there is high risk of access complications, and also lead to the movement with risk of vibration, leak, and progression of the thoracic anatomy. This is the registry, the mother registry from chronic, and the conclusion, the device offers midterm protection. And this analysis from aortic-related mortality in non-urban patients, and will stress it on the thoracic aortic aneurysm, 68% of cases. The study conclusion, acute and chronic aortic dissection patients have low rates of aortic-related mortality in the midterm after TVAR. TVAR offers excellent midterm protection from aortic-related mortality from both thoracic aortic aneurysm and TIV dissection, and aortic-related mortality markedly occurs following the perioperative phase, suggesting that TVAR may prevent aortic dissection and rupture. And here you can see freedom from aortic-related mortality, 93%, and freedom from intervention at 84%. This is my team, me and our colleagues and the surgeon, and we're missing here Dr. Adi and Dr. Rahman Abdullah, surgery and nuclear. And finally, thank you very much.
Congratulations. We are
half an hour delay, so it's allowed only for two brief questions. I'll take the privilege of asking the first one. In the immediate angiogram, on completion, there was still injury, and on the follow-up CT after 2 weeks, the superior heart was still painful. So obviously there was close to around the gap between the superior. How do you explain the superior heart was the
There was a very small osseous of the superior left after compression of the surgery graft should be completely covered. That's why I asked the patient to do after 3 months another CT scan to see the results. The patient came to me, it was completely asymptomatic and no other criteria for treatment.
Question, please.
At the end of the procedure, I noticed that the endogram is the endogram is encroaching on the left carotid. So wouldn't it be related to the anatomy and the proximal landing zone, the distance between the end of the right side of the artery and the first aneurysm? Wouldn't it be more safe to cover by intention the common carotid and do anastomosis to the other one? Surgical anesthesia first, and then you cover the whole thing, cover the origin of the internal and of the common carotid and then these lessons.
We discussed this point, and the landing zone was very safe, but later on you will see the lymph node carotid is really well. We were ready with the cardiothoracic surgeon to do even complete debridement of the neck vessels and reimplanted through the graft.
One more question.
Actually, it's one question regarding this patient, orthoptist, which type of orthoptist? Did you look for connective tissue disease or something like that? Or what do you think about that?
Honestly, we have a lot of causes, but honestly, I don't know the exact cause in this case. What is the nature? It is congenital connective tissue disorders. No, I don't know what they have.
Thank you, Professor Hamid, for this excellent presentation. We are half an hour late, so please come back after 10 minutes. 10 minutes every
هيثم ثانية واحدة ثانية واحدة بس
ثواني ماشي.
لا تطلع
هي ما خدتش عطله يعني الحقيقه ما تعطلنا
الحمد لله.
مش كده؟
بس عشان ده مش كده يعني ما تحطش على اللايف برودكاست، هي دي ده الايرور بقى.
ابقى اوديها اعملها بره يعني هقدمها بره ان شاء الله.
خير ان شاء الله. فين هنا الاتش بي ده ولا فين؟
بقول لك
عارف داخل في اليو اس بي عايز. عارف ازاي؟ يعني ما تغلطش الغلطه دي. برافو.
عارف عشان انا لسه خسران لي شهر اتنين وضايقت قوي.
بس هو نفس السوفت
لا ما كانش فيها كمان فيديوز كتيرة، لكن دي بقى لو وقفت يعني كل القصة عبارة عن فيديوز. المفروض ده تشتغل هي تشتغل على الداتا شو مش أكيد والله يا ابني يعني.
بدل اشتغل فيها لازم الناس شوية يقراها تسيب
أيوة اللي بعد هي دي ماشي دي يمكن يقرا
أعتقد عشان كده عارف عشان أول مرة أشتغل على اللابتوب كده.
طيب بعدين خلاص بقى كده اللي بعدها برضه أنت بتكليك مش كده؟ طب وليه ما نقلش؟
هو محتاج ياخد فترة عشان خاطر يقرا، واحنا أصل لسه بنقول حاجة أنا حتى ما لحقتش أنا سبته هناك بين ودين.
يعني نستنى شوية تفتكر؟ طب
أنا سبته أصلا في ريبليس وجيت يعني.
طيب نستنى. لا أسفة أنا كمان ممكن أكون معطلاك عن الكوبي
لا 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 ولا أي حاجة. لا لا والله أنا آسف روك شغال. لا
روح وتعالى نعملها.
لا لا
بس أنا مش عارفة إذا كان عندي بريك تاني قبل الحلقة بتاعتي. لو عايز تستنى وقت
إيه قول لي في إيه؟ هو أنا عملت بره بشتغل بره بس بعت الفولدر زي ما هو ولا بعت الفولدر زي ما هو بس هو أعتقد لسه في ريبليس. لا بص هقول لك افتح هنا وامشي عليه واعمل على نفس الفيديو ده دبل كليك من غير ما تعمل شغل. هيقول لك ابديت لايبرري لينكس وهيشوف. فاهم قصدي؟ روح عليه كده الفيديو على طول دايركت. هو كده كده شغال. خلينا نروح عليه. شغال. قفلته وفتحته.
طب نستنى لو عايز نستنى.
لا هو بس عشان هو بعته فالباوربوينت نفسه بيقعد يسيرش على اللينكس بتاعت الفيديو بياخد وقت. هي دي ممكن حضرتك بس تقلبي قبل ما هو يكون عرف الفيديوز على الباوربوينت.
طيب احنا بنستنى.
لكن احنا لا حضرتك ممكن تراجع تاني دلوقتي اهو ان شاء الله. كده اشتغلت واحده خلاص كله اشتغل ان شاء الله. دي شغاله.
دي ستاتيك. فالنكست هو نكست سلايد.
ماشي اوكي.
فيري جود.
شغاله.
فيري جود دي شغاله.
بس حضرتك لما تدوسي اول مره بيقف. يعني انا هدوس اهو كليك
ويقف.
يعني هو لو شغال وحضرتك عايزه تجيب نكست الدوسه دي مش هتجيب نكست
هتوقف وممكن اتكلم وبعد كده ادوس تاني.
ممكن لا عشان تكنترولي احسن البوز والبلاي لو عايزه توقفي من هنا من الماوس ده احسن كنترول عشان ما يبقاش فيه كونفليكت وتنزلي على اللي بعده. وكله ما شاء الله كده تمام.
ثانك يو. يعني من هنا لو عايزه افوز وبعدين كونتينيو. كويس ان انا كلمت معاكم في حاجات اول واحد بيبقى عايز يعرفها. ده الفيوز وبعد كده نسيب حتى دي برضه فيها
نفس الكلام. كله بلاي كله كان هو فيديو شغال ميديا بلاير يعني
وبعد كده نكست.
دي قلنا اون كليك
دي لا مش اون كليك.
دي
تاني هنا اون كليك ولا دي مفيش لغايه دلوقتي ولا واحده اون كليك. المفروض كله اوتوماتيكلي. دي بعد اللي بعدها مش كده؟ طيب اللي بعدها دي ستاتيك. تمام. دي اللي احنا قلنا عليها عملناها هايبر لينك ولا مش هايبر لينك؟
انا عايز برضه نفضل عليها شويه عشان هي
خلاص اوكي.
ما بياخد وقت.
طب كويس ان انا يعني استعنت بيك. استنى عليها شويه.
تمام. ده اول فيديو.
ده هيشتغل دلوقتي اوتوماتيكلي.
تمام.
اوتوماتيكلي.
هنرجع تاني.
بليز.
كومبلكس.
لا دي مش كومبلكس.
لا انا هو نيكست من ده لده يعني.
طيب اوكي.
خد بالك دي احسن محاضره في المؤتمر، الناس بييجوا عشان معاه الدكتوره وسيله ويمشوا، فايه خد بالك الانيميشن وصوره الورده اللي في الاخر، خد بالك الكالر جرافيكس. ايوه طبعا.
كونجراتيليشنز دكتور محمد، يعني فعلا مجهود رائع 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 يعني. لا بجد وحضور هايل.
حضرتك هتتذاع لايف عليها.
واو حاجه رائعه.
صوره وخدي بالك حضرتك الكاميرا دي بتبقى شغاله
رائع
بتصور اللي بيتكلم، فتلاقي مربع صغير كده وممكن الاولاد من الموبايل يخشوا يشوفوا حضرتك تدي محاضره.
بيوتفul ثانك يو فيري ماتش يا دكتور محمد. ده نعمل كليك فدي هتختفي وده يبتدي. استاتيك الباقي كله استاتيك. لا مجهود رائع بجد يعني فيري امبرسيف. حلو قوي قوي.
الحاله بتاعت احمد حلوه وحالتين بتوع معهد القلب. يا رب امين يا رب.
استاذ كريم ميرسي قوي.
لايف ستريم شغال لايف. بسم الله الرحمن الرحيم. يا رب بالخير ان شاء الله.
كلهم بقى بيحاولوا بقى يصوروا بالظبط كده. ده
broadcasting. بسم الله الرحمن الرحيم. يا رب تكون موفقة وذو فايدة للجميع.
الرحيم لو سمحتوا الوكيل نقعد عشان السيشن. I have the pleasure to chair this session with Professor Dr. Al-Aisabi. I have the honor to introduce my dear friend, Dr. Ayman Al-Mak. The session about statins in acute coronary bone patients. Dr. Ayman,
الليزر هنا لسه كده مش شغال. اوكي اولا it gives me a great deal of pleasure and it's an honor to be invited to give this presentation. I would like to congratulate Professor Rida Al-Aisawi and Professor Nabil Farag for this wonderful meeting. I attended some of the previous lectures. Very interesting and very interesting interaction. My presentation هتبقى على حاجة مختلفة شوية, which is another important aspect للmanagement and treatment of these high-risk patients. هنا it's a different group of high-risk patients. احنا بنتكلم هنا على acute coronary syndrome and the role of statins. As we know, acute coronary syndrome العيان جاي بسيفير chest pain وانستيبل وبيخش عنايه مركزه وبيتركب له ادويه ومحاليل, لكن دي مانجمنت وبعدين يمكن يتعمل له قسطره ودعامه or perhaps even surgery. However, القصه ما بتوقفش هنا. It's a long-term process. مهم جدا how to prevent recurrence. زي ما احنا عارفين recurrence هنا بيموت, with very high morbidity and mortality. فالقصه لا تنتهي بخروج المريض من غرفه القسطره. Just an overview of the presentation. It's on basically how basic information on acute coronary syndrome, rationale of early use of statins, why early, specifically early use of statins. دي نقطة مهمة جدا. And then what are the clinical studies that support this concept, and what do the guidelines say? طبعا زي ما احنا عارفين acute coronary syndrome is a complication of coronary heart disease associated with more than 2.5 million hospitalizations في العالم كل سنة. The number one reason for admission into the intensive care or CCU units all over the world. It's estimated that a myocardial infarction occurs every 34 جلطة بتحدث كل 34 ثانية في أمريكا. And that one person will die كل دقيقة from a major coronary event. It's the most common high-risk disease في العالم كله. How does it happen? زي ما احنا عارفين, this is the vessel lumen, endothelium, subendothelial matrix, and smooth muscle cells. You get LDL deposition, oxidized LDL becomes deposited, leading to endothelial injury, the first phase. This is followed by the inflammation phase, which is characterized by monocytes, cell adhesion, and migration, with infiltration of monocytes. This is very important. Infiltration of monocytes, macrophages, and foam cells, and migration of these foam cells, and the formation of a fatty streak, further smooth muscle, migration of smooth muscle cells, leading to the fatty streak, and then the plaque, then covered by the fibrous cap. And then, due to some forces such as stress, smoking, hypertension, will lead to rupture of the plaque with exposure of the platelets to the rough surface of the plaque. الكونسبت كلها عبارة عن إن الدم بيمشي في الدورة الدموية لأنه الجدار بتاع الشريان أملس, smooth, completely smooth. البلاك ده is rough. الدم لو لمس أي حاجة rough بيتجلط. طب هو لو في فاتي ستريك, ليه البليتلتس ما بتلمسش الفاتي ستريك حتى لو small 5-10% lesion؟ ليه ما بتعملش جلطة؟ لأنه متغطي بالسموث surface of the fibrous cap. والفايبرس كاب مهم لأنه بيفصل البليتلتس عن the rough surface of the plaque. Once you get rupture due to stress, emotions, severe hypertension, smoking, you get rupture of the plaque ويحصل exposure. يبقى في مجال إن البليتلتس تلمس البلاك وتعمل thrombus and you get into the acute coronary syndrome complex. طيب احنا عرفنا كده البيسك هيستولوجيكال ميكانيزم. احنا عارفين ان العيانين دول بنديهم ستاتنز، وان ستاتنز كويسه، بس actually هي بتعمل ايه؟ What is the real benefit? And this is basically the premise او الفكر ما وراء the new guidelines. انه studies احنا كلنا اي دكتور قلب او مش قلب بيجي له عيان وبيقول له اصل انت عندك ضيق في الشريان. اول سؤال العيان بيساله ايه؟ اول سؤال، طب ممكن اخد دواء يقلل الضيق يا دكتور؟ تالي كلنا سالنا السؤال ده مليون مره. مش كده برضو؟ طول عمرنا بنقول لا 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 مفيش دواء بيقلل. Now the data shows that you can actually decrease the volume of the atherosclerotic plaque. This is multiple studies. This is LDL. هنا the change in percent atheroma volume. الايفس احنا عارفين الايفس اللي هو الايكو اللي جوه الشريان بيبص على حاجات كتيره في الشريان، بيقيم حاجات كتيره في الشريان، وبيحدد لنا البريدكتورز اوف high risk and low risk. The number one predictor of high risk بالايفس is extent of atheroma volume. من كل الحاجات اللي الايفس بيقيسها هو ده اهم حاجه، extent of atheroma volume. كل ما بتبقى اكتر كل ما البيشنت بيبقى high risk, more high risk. This is the use of statins to decrease LDL and the subsequent وتأثير انخفاض رقم ال LDL على atheroma volume. These studies ال LDL هنا 50 60 لحد 120. This is the mean LDL. كل دول really didn't have any major change في الاتروما volume. However, when you decrease the LDL أقل من around 75 as shown in the asteroid trial, you don't only decrease the LDL والرقم قل وخلاص، لا ده ال LDL بيقل والأثروما volume بتقل. اوكي؟ واضحه؟ لما هنا بروجريشن، هنا لتحت الخط، فوق الخط ده بروجريشن، تحت الخط ده ريجريشن. فانت هنا when you were below 75 هنا the asteroid actually reached 60 LDL 60. You had a significant decrease in atheroma volume. This is very important documentation to the true significant effect of decreasing LDL to certain levels. The slide I think is basic, كلنا عارفينه. طيب احنا قلنا early use of statins. Why وازاي؟ العيان اللي بيجيله stable engine, unstable engine او infarction كلنا عارفين انه high risk. بس هو امتى high risk؟ the most high risk period في العيانين دول is the first month. ده عدد الشهور from hospital admission، ده number of death. هتلاقي ان it is highest في الفترة الأولانية، وبعد شهر ونص it stabilizes ليه؟ الهاي ريسك ماتوا وفضل لك اللو ريسك ففضلت ستيبل وكونستنت من شهر ل6 اشهر. يبقى the most high risk period هي الشهر الاولاني. واضحه؟ طبعا احنا هي هاي ريسك في الاكيوت كورنيال سيندروم، الانستيبل انجن والانفاركشن. الستيبل انجن از ذا سيم، الاحمر ده الستيبل انجن، لكن الاثنين التانيين الاورنج والبنفسجي الموست هاي ريسك بيريد الشهر الاولاني. وبالتالي مهم اي حاجه بعملها في الفتره الاولانيه عشان تشتغل من بدري. طبعا ده برضه هيخلينا نرجع لورا ونقول سبحان الله زمان قبل ما يبقى فيه بقى الثرومبوليتكس ستريبتوكاينيز والبي سي اي البالونه، كان العيان بيتقال له انت جالك جلطه تقعد في البيت 40 يوم ما تتحركش من السرير. ويقولوا العيانين بيبقوا كويسين، يس، لان هم بيموتوا وما بيجيلكش بعد كده الا العيانين اللي عاشوا، اللي عدوا الهاي ريسك بيريد. كريتيكال ايشو اللي تعمله في الفتره الاولانيه because it is the most high risk period. طيب اللي هيعمله ده هيجيب نتيجه ولا مش هيجيب؟ ما انا ممكن ادي الدواء، لكن ايش عرفني ان الدواء where is the evidence ان الدواء اللي هديه actually هيجيب نتيجه؟ هنا this is a study from the JACC Journal of American College of Cardiology. خد العيانين قسمهم لعيانين اللي خدوا lipid lowering therapy بدري واللي ما خدوش من اول يوم. هتلاقي ان this is survival، يعني كل اللي خدوا lipid lowering agents من بدري السرفايفل بتاعهم كان about 99%. اللي خدوش lipid lowering therapy نتيجه لانه هتلاقي ان السرفايفل قل قوي في الفتره الاولانيه، اهو ده 30 ل 60 يوم. شوف الدراماتيك ديكريس في السرفايفل وقل gradually بعد كده. Therefore this is evidence of giving lipid lowering therapy من بدري is beneficial and saves وبتنقذ ارواح البشر. This is data من الجاستو والبريزم، two very big studies. الجاستو ترايل لو نفتكر ده اللي كان عامله إيريك توبل ايام ما كان في كليفلاند. جاستو ترايل جاستو 2B was a retrospective analysis of 12630 acute coronary syndrome patients with or without ST elevation. He looked at mortality at 30 days and 6 months, and it was significantly reduced in patients receiving lipid lowering therapy. This was a 52% reduction to 6 months mortality after adjusting for other variables. يعني adjusting for age, other risk factors. دخل الحاجات دي كلها في الحسبة بتاعته وبرضه لقى انه there was a 52% reduction in 6 month mortality. البريزم ترايل لو نفتكر البريزم ترايل اللي هو كان بتاع الاجراستات في الاكيوت كورونري سيندروم، هنا they did a retrospective analysis ل 1616 عيان. 302 patients were continued on statin therapy. The death MI rate at 30 days was significantly lower in those patients who received the statin from day one, and the p-value was very significant. وبالتالي عندنا evidence from two big studies 12600 عيان and this is 1616 عيان. الاثنين confirming the benefit of early use of statins. What are the potential mechanisms of benefit of statins in acute coronary syndrome? طبعا obviously LDL reduction in chylomicrons, VLDL remnants, IDL and LDL, intermediate density lipoprotein, and LDL cholesterol. It restores endothelial function, maintains smooth muscle function, anti-inflammatory, and leading to decreased thrombosis. It's important to remember they are not equal. Statins differ significantly in terms of these effects and mechanisms. In the Swedish registry, presented in the European Society of Cardiology Congress, Swedish registry, early statin and revascularization significantly reduced mortality. الدول بتاعت اسكندنافيا، السويد والدنمارك بيعملوا ابحاث كويسه جدا، ومهم جدا ان احنا نركز ونهتم بالابحاث بتاعتهم. ليه؟ اولا الدول دي البوبيليشن بتاعتها حوالي 3.5 ل 4 مليون، يعني شبرا كده مثلا، وكلهم متغطيين بالهيلث كير سيستم. فهم عندهم داتا بيس لكل العيانين وكل حاجه بتاعتهم بتبقى ريكوردد، لان هم بيحسبوا كل حاجه، يشوفوا الايفكتس ويشوفوا الايفكت اوف تريتمنتس اللي بيعملوها على المورتاليتي عشان يقرروا البوليسي واتجاه الهيلث كير سيستم كله. فحتى من قريب اخر ستادي في الثرومبس اسبريشن التيست ترايل معمول عندهم، وقالوا ان البحث ده هيغير الاسلوب اللي بيتعمل بيه الابحاث العلميه في العالم كله. فمهم جدا ناخد بالنا من الدول دي. السويدن والدنمارك بيعملوا excellent studies على عدد كبير جدا من العيانين because الداتا بيس سمول نسبيا وكله متغطي بالهيلث كير سيستم، الناشونال هيلث كير سيستم. الستادي ده قال ايه؟ الستادي ده لقى انه من الهوسبيتال ادميشن if you follow the patients 1 year المورتاليتي قلت بس بالريفاسكularization by 36%, by statins by 34%. Obviously الريفاسكularization هتقلل early, acute. Longer term will be due to the statins. Combination revascularization and statins decreased. That led to relative risk reduction mortality at 1 year of 64%. مفيش حاجه اسمها حامل ده ومش حامل ده او حامل ده ومش حامل ده. You have to give both. زي في الاكيوت انفاركشن لو نفتكر الستريبتوكاينيز بيقلل المورتاليتي باي حد فاكر بقد ايه؟ حد فاكر ستريبتوكاينيز في الاكيوت انفاركشن بيقلل المورتاليتي بقد ايه؟ افندم؟ Yes, it's 22 to 25%. طب والاسبرين؟ الاسبرين في الانفاركشن افندم؟ الستريبتوكاينيز قلل المورتاليتي by 25%, الاسبرين by 23%, almost the same. Combined, they decreased the mortality by about 47%. ده في ISIS trial. You're not going to give just aspirin للعيان بتاع الانفاركشن. You're not just going to give them streptokinase, you give both. نفس الحكايه هنا. You will do the revascularization, بس دي مش نهايه القصه. You would have to do both, and you do get cumulative effect مع بعض هنا. طيب, what do the recent guidelines say? 2013 ACC AHA cholesterol treatment guideline recommendations. الجايدلاينز المره دي كانت مختلفه لان هي بتفكر من in terms of global, اللي انا كنت لسه بقول عليه الدنمارك والسويد بيبصوا على كل العيانين مش بعض العيانين او العيانين اللي في حته وحته ثانيه, لا كله الجلوبال. فقالوا انه we will take it prescribe the statins according للريسك, and accordingly عندهم 4 high risk categories, groups of patients. clinical العيان اللي اثبت انه هاي ريسك انه جاله clinical atherosclerotic cardiovascular disease, او العيان اللي هاي ريسك LDL اكثر من 190, diabetes age 40 ل 75 with an LDL من 70 ل 189, or those with an estimated 10-year risk of atherosclerotic cardiovascular disease of more than 7.5%, age 40 ل 75, and with an LDL 70 to 189. These are the 4 groups of patients اللي بيعتبروا high risk and you should give them treatment. حد هيقول لي بس احنا هنحسب ازاي الهاي ريسك؟ برضو ده اختلاف دول. هم في امريكا دلوقتي يعني في مؤتمر السنه اللي فاتت بدل ما ناخد الشنطه في التي سي تي, شنطه المؤتمر ما كانش في شنطه مؤتمر, ادوا سمارت فون وزعوا على كل ال 12 و500 الف اللي حضروا المؤتمر سمارت فون. ده يوريك قد ايه هم بالنسبه لهم السمارت فون ده كل الناس عندها, وبالتالي بيحط البروجرام وهو قاعد قدام العيان تك تك 30 ثانيه بيحدد الريسك بتاعه, واكوردنجلي هيقرر هيعمل له ايه او مش هيعمل له ايه. وجرادجولي ده هيجي عندنا على فكره, كل شويه الحاجات بترخص وهتبص تلاقي سمارت فونز عند كل الناس, وبالتالي you will be able to calculate the risk والعيان قدامك, فمش عايز حد يتخض يعني. طيب, accordingly they determined ان العيانين دول based upon the LDL, لو انت عاوز to decrease it by 30 to 50%, this is moderate intensity statin therapy in the form of atorva 10 to 20, rosuva 5 to 10 milligram, simvastatin 20 to 40 milligram, or pravastatin 40 milligram. If the patient, ده انت عايز تنزل له ال LDL by 50% or more, يبقى you have to give higher doses of the drugs, atorva 40 to 80 and rosuva 20 to 40. It's the treatment decision for the 4 statin benefit groups اللي احنا اتكلمنا عنهم. Adults aged more than 21 and a candidate for statin. يعني واحد من ال4 جروبس اللي احنا شفناهم من شويه اللي هو atherosclerotic جاله documented unstable angina, acute coronary syndrome or infarction with an age less than 75, high intensity statin, moderate intensity if not candidate for high intensity statin. يعني لو ما استحملش high intensity or لو ال LDL بتاعه already is quite low. Or if the age is more than 75, or if not a candidate for high intensity statin, also you give moderate intensity. Like basically you go for high intensity, aiming to decrease the LDL towards the level اللي وريته في السلايد الاولاني in the range of 60 اللي هو بيقلل الاثيروما فوليوم. طبعا لما تقلل الاثيروما فوليوم هتقلل الايفنتس على المدى الطويل. Again, for LDL more than 190, you go with high intensity statin. ده القاعده. Otherwise, moderate intensity if not candidate for high intensity statin, or is not able to tolerate high intensity statin. Diabetes, moderate intensity statin, and those with an estimated 10-year risk of more than 7.5, you give high intensity statin زي ما قلنا في السلايد الاولاني. For those with an estimated 10-year risk of pooled cohort equations greater than 7.5, 10-year risk of a fatal or morbidity, high morbidity or mortality from the disease, then you give moderate to high intensity statin. فدول الجروبس الهاي ريسك جروبس اللي احنا بنديهم basically high intensity or moderate intensity اللي هو lower doses of the statins. A new perspective on LDL and or non-HDL treatment goals, lack of randomized controlled trials to support use of specific targets, no recommendations for specific goals in primary or secondary prevention, no data supporting routine use of non-statin drugs combined with statin therapy to further decrease events. In high-risk patients who are insufficient response to statin, then you can add non-statin drugs. Rosuvastatin studies, the LUNAR study compared rosuvastatin 20, rosuvastatin 40, and atorvastatin 80 at 12 weeks. Numerically, there was no major difference in the results. However, in the early, this is rosuva 20, rosuva 40, and atorva 80. You look at the primary endpoint of the average change in LDL from baseline. Atorva 80 reached 42, rosuva 40 reached 46, rosuva 20 gave the same result as atorva 80, 42 versus 42. In the LUNAR secondary endpoint, look at the HDL. Atorva increased by 5.6, but for rosuva 40, the HDL زاد ب 12% and by almost 10% for rosuva 20, and this was statistically significant. But benefit هنا was in increasing the HDL. In the Centaurus, comparing rosuvastatin 20 with atorvastatin 80 in ST elevation infarction, at 1 month, it was significantly decreased by 44 versus 42. P-value was significant in the first month اللي هي الهاي risk period. At 3 months كانوا زي بعض الرسوفا 20 والاطورفا 80. لكن المهم ان الهاي risk period اللي اتكلمنا عنها في الاول الفيرست month it was significantly in favor of rosuvastatin. Regarding the side effects, كانوا زي بعض الأتورفا and the rosuva, although p-value was not significant, although numerically الأرقام كانت أقل شوية 4.4 versus 5.4. p-value is not significant, لكن مطمئنة أنه كانت أقل في الرسوفا عن الأتورفا 80. Regarding lab tests, ALT والCK كلهم كانوا very low. في النهاية you're talking about 0.2, 0.5 or 0.0. كلها الحقيقة أرقام مطمئنة جدا على safety of these drugs. So this is in patients undergoing PCI, Rosuva 40. Prior to PCI, هتلاقي ان the incidence of MACE, major adverse cardiac events, at almost 1 year of follow-up was decreased by 51% in the group who received rosuvastatin compared to not receiving. اللي هو basically زي يفكرني بالليبس ستادي بتاع الاسكول. This is the same thing with the rosuvastatin, showing a 51% decrease in adverse events. I'm almost finished. In terms of combined endpoint, conclusion of the study, a significantly better event-free survival at 1 year was observed in the rosuva group P.002. So several clinical trials, in summary, have indicated the benefits of early treatment of acute coronary syndrome. Aggressive LDL lowering has previously been shown to be beneficial in improving cardiovascular outcomes. With statins, rosuva has been shown to be more effective in reducing LDL to target levels than atorva and simva. Recent studies proved that rosuva can benefit ACS patients, especially in the high-risk first month. Thank you for your attention.
That's why if we're back to the old study, the focus and the application study, by the analysis, the subset of peripheral vascular disease patients, the study showed that there was risk reduction of major vascular disease in peripheral vascular disease subgroup patients by 1/6 of its value compared to those who are not receiving statins. Not only this, but only that many randomized controlled trials have shown in the peripheral vascular disease patients that the statin use can reduce the walking distance, can increase the walking distance in most patients having the intermittent medication because of the peripheral vascular disease. That's why we wanted to highlight the value of using statins in peripheral vascular disease as well. And my question to Professor Agnew, if one of my patients is heavily stated and has significant side effects, what guidelines prescribe now as a substitute for statins?
I think we have multiple choices. يعني اولا احنا when we're talking side effects احنا بنتكلم على which type of side effects. I think the most common side effect هو الميالجيا وآلام عامة في العضلات. هل هنتفق ان دي the most common side effect؟ I think انه what I do مع العيانين دول اولا number 1 بقول له هنوقف الدواء اسبوع وشوف الاعراض دي اتحسنت ولا لا. لانه كتير قوي بيكون هو قاعد مع ناس قرايبه واصحابه ومعارفه فيقول له ده انا لما خدت الدواء ده جالي كذا، فيقول يبقى هو الدواء عمل لي كده. sometimes بيوقف الدواء والاعراض بتتحسن، وفي very frequent بيوقف الدواء يقول لي انا زي ما انا، بيكون في سبب تاني. فالنمره 1 لازم اتاكد ان الدواء هو المسؤول، وفير انف اقول له هنبطل اسبوع 10 ايام ونشوف اتحسنت يبقى اكيد الدواء هو المسؤول. طيب وقف وتحسن وانا عايز اديله الدواء، عندي كذا اوبشن. لو العيان accepting sometimes والدواء لو الدواء كان جايب نتيجه كويسه منزل ال LDL كويس والعيان فاهم اهميه ان الدواء ده كان كويس بس كان عامل له اثار جانبيه وعنده استعداد، I sometimes started slowly at lower doses. Sometimes يوم بعد يوم اعمل له develop tolerance until he can go to the maximum dose he can tolerate without symptoms. وفي بعض نسبه محترمه من العيانين بعمل كده معاهم and they do tolerate the medicine. نسبه كبيره من العيانين يبقى قفل من ناحيه الدواء. then I shift to another drug. الother drug ببتدي بقى برضه نفس القصه. I start at a lower dose وجرادوال كل اسبوعين ابتدي ازود الجرعه جرادوال. فده we have options ومعظم العيانين بقدر one way or another to reach to give them a statin and reach target goals of يعني decreasing the LDL. أفهم؟ الأوميجا 3 fatty acids البنفيت بتاعتهم is primarily at the cellular level, but it doesn't really العيان هنا بيشوف تحليل كوليسترول وارقام عاليه وعايز يشوف الدواء نازل له الارقام. الاوميجا 3 فاتي اسيدز ما بتنزلوش الارقام although it can be beneficial at the cellular level. It doesn't really decrease the LDL to the numbers that are enough to decrease the atheroma volume. They are supportive rather than a main يعني كدواء اساسي في العلاج. اتفضل حضرتك. الCPK absolutely.
بس هل لو العيال عنده ميلانجي اقدر اعمل الCPK علشان اقول السبب ان انا حاجتين بالسبب؟
السؤال ده مهم جدا. انا I did this. قعدت فتره كنت اللي بيجي لي مريض بالوجع I checked الCPK. معظم الوقت اللي انا شفته ان الCPK ما كانش بيبقى عالي وهو حتى is called myalgia rather than true myositis, وبالتالي in many cases الCPK بيبقى normal وعنده الاعراض وقف الدواء الاعراض بتروح. It's a myalgia more than true myositis. في نفس الوقت انا عندي عيانين بالصدفه ما عندوش اعراض. He had no complaint بس اتقال له المفروض تعمل كده فراح محلله وجابه لي لقيته عالي جدا 600. ف اتخض طبعا وقفنا الدواء شهر. انت بتشتكي من حاجه؟ لا انا كويس. طب انت كنت بتشتكي من حاجه؟ لا ده انا عملته كده عشان الناس قالوا. رجعنا بعد شهر حللنا 700 موقفين الدواء والراجل خاف. بعدها بشهرين في الرينج. sometimes لما بترمي شبكه بتحلل بتلاقي حاجات incidental findings لا هي اثرت فيه لا عملت له اعراض ولا اتحسنت وخلاص هو قال طالما خلاص انا ما بشتكيش انا هاخد الدواء. المهم هو كان عامل multiple procedures فطبعا كنا متفقين على اهميه ان احنا ننزل فقال خلاص انا هاخد الدواء and he did well. sometimes لما بنعمل تحليل كتير هنلقط حاجات قد يكون بالصدفه البحته لكن absolutely لو في اعراض والCPK عالي absolutely لازم نوقفه كده ولا كده. لكن حتى لو CPK مش عالي وعنده اعراض هوقف الدواء. and I check. اتفضل يا دكتور.
بس I would like to say something about when to stop statins due to inhibition of liver enzymes or CKD. Inhibition of stop statins is threefold increase in liver enzymes or tenfold increase in the CK protein. Otherwise, you don't belong to
هو برضه regarding liver enzymes لو liver enzymes عليت we have multiple options. دايما بقول للعيانين بتوعي القصه ان الادويه دي بتشتغل جوه الكبد وبالتالي sometimes بتاثر على الليفر انزيمز بتاعنا. لو عليت قدامي كذا حاجه. نمره واحد اوقف الدواء واحلل انزيمز رجعت ارجع الدواء او اقلل الجرعه او ما اوقفش الدواء خالص واحلل بعد 3 4 اسابيع هلاقيها رجعت. and frequently والمريض على الدواء keep him on the medicine there is a transient elevation of the enzymes وبترجع تاني. We don't fully understand the precise mechanism لكن we have data. لو نفتكر في ال HPS 5-year follow-up 20,000 عيان نصهم خدوا الدواء ونصهم ما خدوش. At 5 years the incidence of the elevation of liver enzymes for those who took the statin versus those who did not take the statin at 5 years, الانسيدنس كانت the same. 20,000 عيان 10,000 خدوا الدواء و10,000 ما خدوش. Incidence of elevation of liver enzymes عند 5 سنين was exactly the same.
Present in the Play stores and in the iStores for the smartphone available.
بالظبط.
Can download this help us to choose what's the intensity of the treatment as regards to the risk factor.
بالظبط.
This number one. Number two, I would argue about the usage of the CDK as a motivation for myositis prevention. I do believe it's included in the latest guidelines.
Yes.
Issued that year.
Yes, this is true. Thank you.
شكرا يا ايمن. very presentation and we'll come to the end of this session and we call for the chairman of the next session.
مديرية ما جاش خطبها ماشي الشغل.
This meeting and all the group of river personalities. And first, I would like to present Dr. Yasser Son, to talk about the German our community management step by step.
Bismillah ar-Rahman ar-Rahim. Good afternoon, my dear professors. Good afternoon, my dear colleagues. First of all, I would like to thank the organizing committee for inviting me to share our new experience with TVAR and EVAR management. Actually, we started this project in National Heart Institute 1 year ago, as Dr. Hamdi Suleiman mentioned that. And we did a lot of cases of TVAR, but still we have a limited experience in EVAR because the low number of cases we did till now, 3 cases till now, 1 straightforward case and 2 cases with extension limb. And from the address of my presentation, management step by step, it's nice chance to represent the first case of EVAR we did in National Heart Institute. It's a straightforward case, but first of all, we should know the magnitude of the problem. Aortic aneurysm, pathological dilatation of the normal aortic lumen involving 1 or several segments. The shape may be fusiform, which is common, or circular. Pseudoaneurysm, well-defined collection of blood and connective tissue outside the vessel wall. The prevalence of abdominal aortic aneurysm are never detected. Approximately 70 to 80% of abdominal aortic aneurysm patients are asymptomatic at initial diagnosis. Abdominal aortic aneurysm are generally discovered during procedures to diagnose unrelated medical conditions. Nearly 200,000 people in the United States are diagnosed with abdominal aortic aneurysm annually, and 15,000 die each year from ruptured abdominal aortic aneurysm. 45,000 to 50,000 patients undergo surgery. Abdominal aortic aneurysm are more prevalent in people over the age of 60 years and more common in males than in females. The symptoms of abdominal aortic aneurysm may be asymptomatic, and this is the most common presentation. May be a pulsing feeling in the abdomen, similar to a heartbeat, or severe sudden pain in the abdomen or lower back. Aneurysm may be about to rupture. On rare occasions, feet may develop pain, discoloration, or soreness because of material sheet from the aneurysm itself. Screening for abdominal aortic aneurysm are most often found when a physician is performing an imaging test such as ultrasound, hip X-ray, CT scan, or MRI for other conditions. So, fusiform dilatation of abdominal aorta more than 1.5 times its normal diameter, considered this is the aneurysm. Because normal aorta is 1 to 2 centimeter to 4 centimeter, and the iliac artery 0.6 to 1 to 0.2 centimeter. So aneurysm of aorta considered when exceeding 3 centimeters and the iliac exceeding 2 centimeters. The incidence of abdominal aortic aneurysm, 5% of elderly population more than 60 years old, and 6 to 9 times more common in males. Relative risk, 11.6% in patients with first degree relative with non-abdominal aortic aneurysm. Multiple risk factors may be responsible for this disease as atherosclerosis, hypertension, smoking, male gender, advanced age, connective tissue disease, and risk factors for rupture may be diastolic hypertension, initially large size at diagnosis, COPD, symptomatic, recent rapid expansion. So standard EVAR is approached for aneurysms that begin below the renal arteries, where there exists an adequate length of normal aorta, which is called the proximal aortic neck. It's very important for landing zone of our graft, for reliable attachment of the endograft without leakage of blood around the device, which is called endoleaks. Patients with aneurysms require elective repair of their aneurysms when it reaches a diameter large enough, typically greater than 5.5 centimeter, or symptomatic, where the risk of rupture is greater than the risk of surgery. Repair is also warranted for aneurysms that rapidly enlarge or those that have been the source of emboli, debris from the aneurysms. Lastly, repair is also indicated for aneurysms that are the source of pain and tenderness, which may indicate impending rupture. The options for repair include traditional open surgery or endovascular repair. Before patients are deemed to be a suitable candidate for this treatment, they have to go through a rigorous set of tests. These include a CT scan of the complete thoracic, abdomen, pelvis, and the blood tests. The CT scan gives precise measurements of the aneurysms and the surrounding anatomy. In particular, the caliber, tortuosity of the iliac arteries, and the relationship of the neck of the aneurysm to the renal arteries are very crucial and important. In certain occasions that the renal arteries are too close to the aneurysm, the option may be open surgery, or the custom-made fenestrated graft stent is now an accepted alternative to doing open surgery. Screening for abdominal aortic aneurysm. There is a lot of recommendation for screening, but the United States Preventive Services Task Force recommended that men 65 to 75 years who have ever smoked, no for or against men 65 to 75 years who have never smoked, doesn't recommend screening for women. Society of Vascular Surgery Medicare screening recommended that men who have smoked at least 100 cigarettes during their life, and men and women with a family history of abdominal aortic aneurysm, and only screen patients who are candidate for repair, surgical or endovascular. And this picture shows how to diagnose the abdominal aneurysm by ultrasound and CT. As you saw, this is the diameter of aorta in ultrasound and here in CT. And this is CT three-dimensional reconstruction showing the aneurysm and the relation between renal arteries and the aneurysm and the diameter of neck, which is very crucial in our work. And the angiogram also helpful for identifying the aneurysm from beginning to distal in iliac arteries. Anatomic requirements for EVAR. Actually, we need anatomic requirements to decide this patient is eligible for EVAR. Includes length, angulation, and the diameter of infrarenal neck, as more than 60% of neck angulation may lead to more than 70% of complication, and minimum adequate length of infrarenal neck allowed is 8 millimeter. And this picture showing us the graft and the relation between the graft and the renal arteries. And this diagram, step by step, to how to deploy our graft stent. We go through right femoral artery till we pass very slowly the aneurysm here, and we landing above the renal arteries, and then we started to deploy our graft for one cell, and then we will go back by the whole system to be sure that the renal artery is not affected by this graft, by angio, and then we complete the deployment till the right iliac, right common iliac, and then the contralateral contralateral graft will be completed as this, and this is the picture at finally after deployment of abdominal aortic aneurysm graft. What is the drawbacks of EVAR? Drawbacks, we need frequent CT scan and follow-up 1 month, 3 months, 6 months, 1 year, and every year thereafter, as 90% infectious at 6 years may be, this is the cause, and late ruptures may be also a complication, and up to 25% of patients need re-intervention within the first year because the complication of EVAR, and the most common complication we know is are endoleaks, and the endoleaks multiple types. Maybe you see how the leak go to aneurysm again, and from the position you can order the type of aneurysm, type of endoleaks. This is our case, our first case in National Heart Institute. Is 64 years old male, smoker, ischemic heart disease, high blood pressure, complained of pulsatile beats in his abdomen, and diagnosed as abdominal aortic aneurysm. And this is a 3D reconstruction of his abdominal aneurysm, and with enough infrarenal neck and also good landing zone. And this is the CT showing the larger diameter of aneurysm, and this is the diameter as maximum diameter reaching about 32 millimeter. And this work sheet up of for choosing the graft, because here the graft will be the maximum diameter of the aneurysm reaching 42 millimeter. And this is additional finding we got from the multi-slice CT, normal renal arteries, abdominal aortic aneurysm measuring 4.2 centimeters in 4.2 centimeters, left common iliac measuring 1.4 centimeter and 1.3 centimeters, and also right common iliac. And this is our case by angio. And this our graft. You go slowly upward, and now angiogram again to landing zone at infrarenal neck. And now we started to deploy our graft. And this angiogram again to be sure that we far away from the renal arteries. And after that,